name is Professor Fatma Some, Associate Professor in Internal Medicine, Moi University School of Medicine. I'm going to co-chair this session with my colleague, Dr. Murunga, consultant gastroenterologist in Nairobi. I think you have had an opportunity to encounter with Dr. Murunga the other day. Let me start by wishing all the women happy International Women's Day. Clap for ourselves. Congratulations for coming this far. We've gone through many milestones, and we hope God will give us more to go through. So welcome to this session, the gastro session. I will start off with the first two presentations, and then my colleague will take over from there. It looks like they haven't put up the presentations. Okay. So the first presentation is by Dr. Smita Devani, consultant gastroenterologist, Aga Khan Hospital. For many years, strong member of Gastro Society. I've known Dr. Devani from her internship days. We've been friends. Dr. Devani is going to take us through current management of ulcerative colitis and Crohn's disease. I've really shortened her bio, it's very long, but I think for today's purpose, it's important to know that she is a consultant gastroenterologist at Aga Khan Hospital. Welcome, Dr. Devani.
Thank you, Fatma. Okay, gastroenterology is quite a specialized subject, but IBD is even super specialized. So I don't anticipate a huge crowd here, but I'm sure things will build up. So my topic is on IBD in Kenya. However, I would like to point out that this is not such a rare disease anymore. All the gastroenterologists are seeing them, and the numbers are increasing as we increase our Western type of diet. So we need to be aware that this is happening. So the two main types, and I'm saying two main types, not two types, are Crohn's and ulcerative colitis. So ulcerative colitis affects mostly the colon, while Crohn's affects the ileum and the colon, but as in younger age, it can affect the upper GI tract as well. Ulcerative colitis is further subdivided, and the reason is important is for management, number one, and number two, for the treatment, you need to identify exactly what kind of ulcerative colitis it is. So you have proctitis, which is confined to the rectum, proctosigmoiditis, distal or left colon colitis, pen colitis, which is full colon, and then you have backwash ileitis. It's strictly speaking not ulcerative colitis, but it's just the inflammation that's extending beyond the terminal ileum valve. Crohn's can affect anywhere, usually the small bowel and the large bowel, and don't forget it can be anal as well, anal Crohn's, which is a very distressing syndrome. And in young children, as I said, can present with esophageal, gastric, and duodenal lesions as well. So when you're doing a cross-section of the bowel, that's a normal colon. Ulcerative colitis is confined largely to the mucosa and submucosa, while Crohn's starts going into the muscularis and through the wall. So this is a cross-section cartoon of what kind of happens in the Crohn's and ulcerative colitis. I'm going to skip that. So the presentations are bimodal. One is at 15 to 30, which is young, but we have had patients as young as 6 years. And as pediatric gastroenterologists, people are actually seeing younger patients. And the second peak is at 60 to 80. So don't disregard people who come with diarrhea at an older age. Ulcerative colitis, the male-female ratio is 1:1, while Western figures, Crohn's is more common in the females. Although in my cohort, it seems to be more common in the males here. Smokers have a lower risk of developing colitis, but in Crohn's, it's increased. And if you have one relative who's got either UC or CD, there's a 10% risk of family member having Crohn's or UC. I have several family members of one family, at least two that I know, who have presented either with ulcerative colitis or Crohn's. It doesn't necessarily have to be ulcerative colitis. So what actually happens in IBD? Who gets IBD? Why do they get it? What triggers it? There seems to be a genetic predisposition, which we know about. In fact, there is right now a global research going on the salivary samples on IBD patients. Then it seems like an immune system that is triggered, and environmental triggers as well. At one time, it was thought it's Klebsiella that is triggering because the antigen presents to the lumen and it triggers it. But I don't think that's really been proven. This is a complex cartoon. Just to explain very briefly, once the trigger sets in, you get all the luminal bacteria going into the mucosal layers, exciting the Peyer's patches, the macrophages, the dendritic cells, TGF-alphas, interferons all come into play, and the infection goes on. So history in these patients is going to be very important. Please don't keep treating the same patient with amoeba, which we often see, but it's becoming less so. People are generally becoming more aware that it's not all amoeba. So treat amoeba, sure, certainly. Treat for worms, certainly. But make sure, if the history is more than 1 month and the patient is having diarrhea, abdominal pain is not predominant in ulcerative colitis, but more in Crohn's. Vomiting, weight loss, there's extraintestinal manifestations, fistulas, perianal disease. Perianal disease, I have surgeons operating on these again and again. Please think about Crohn's disease as well. Fevers and recurrent flare-ups. Duration, as I mentioned, over 1 month, start thinking there's something a bit more going on. Obviously, in our setup, we always think about cancers and all, but think of UC as well. Stress does precipitate IBDs. Don't forget the other conditions that can simulate TB, amoeba. We have found all of them in our setup. Don't forget travel history, medications like non-steroidals. There is something called enteropathy, antibiotics causing difficile, and steroids, which makes your immunity low. Family history and smoking. Now, examination is the routine one. The important ones are to check for perianal abscesses, perianal fistulas, check for bowel sounds. In Crohn's, you tend to feel masses, which are very gurgly, because there are strictures formation, of course hepatomegaly, and then the other mouth, aphthous ulcers, arthropathy, eye manifestations, namely uveitis, episcleritis, erythema nodosum. If you've seen one of them, you'll never forget it, jaundice and rash. Simple things first. Stool examination, check for Clostridium difficile. You don't want to miss out. People are given antibiotics for whatever, H. pylori, for diarrhea, and you do find patients with C. diff. You treat it first. Occult blood, leukocytes, and once you start getting into thinking about UCCD, do a calprotectin levels. Calprotectin levels can be raised in other conditions. It's fairly widely available now in major hospitals, so please do that because that's your baseline. And then subsequently you can use it for monitoring because it's a cheaper way of monitoring. Of course, the usual blood counts, iron studies, because often they get anemic. ANCA and ASCA, largely because there's some This is to differentiate what's called undifferentiated IBD, where you don't know if it's Crohn's or ulcerative colitis. You can use that as a guide to help you out. But sometimes it will manifest later on. I have had patients where I thought it was UC and later on turned out to be Crohn's. You're going to start on immunosuppressants, so please check your HIV, hepatitis B, hepatitis C, and varicella zoster. Simple things, again, X-rays, barium enemas where there's no capacity for colonoscopy or sigmoidoscopies, X-ray, and DEXA scan is largely for patients where we're going to prescribe steroids even on a short-term basis. Oops, sorry. Okay. Things are coming on, good scopes. Use your dyes, chromoendoscopy, magnifications. Capsule is available in Kenya now. MRCP for patients where you suspect PSC, but don't forget, PSC may not be detected on MRCP, and you eventually may have to resort to a biopsy. Double single enteroscopy, not available in Kenya yet, but I'm sure. Point of care ultrasounds are coming into place, especially for Crohn's. CT scans and enterographies are available now in Kenya. So this is just a differentiation. So when you get terminal ileal involvement, it's more likely to be Crohn's unless you get the backwash. Colon, it can happen in Crohn's, but usually it's coloterminal ileum. Rectum is usually ulcerative colitis, but anal is Crohn's. Bile duct usually is with ulcerative colitis. Lesions are skipped while ulcerative colitis extends all the way from rectum and then goes upwards or proximally. Endoscopy, continuous ulcers, while these are serpiginous, snake-like ulcers. The deep ulcers in Crohn's, fistulas are more common in Crohn's, and stenosis as well. We have several patients where we are managing their stenosis. Crohn's is also regarded as an autoimmune condition, and there's a cytokine response usually with Crohn's. Now, you may get granulomas. Don't forget, granulomas can happen in Crohn's, but if you get caseating granulomas, then you start thinking about TB because they can simulate one or the other. Surgery, try not to operate on patients with Crohn's because it just recurs. In ulcerative colitis, it may actually be curative, where you just can't control it. As I said, Crohn's, higher risk for smokers. So what's our goal as doctors? Maintain and improve quality of life because they have a miserable life. First thing they do anywhere is where is the washroom? Okay, so I know I'll have to sit at the edge of the cinemas or wherever so I can go to the washroom if need be. So it's actually quite a miserable life. We need to make their life better. So idea is to terminate any flare-ups and induce remission, improve the symptoms, whatever they're getting, pain, anemia, whatever, prevent and cure any complications that happen, cost-effective treatments. That's where our problem lies in Kenya. Avoid surgery, replace any vitamins that may be deficient. Now, there are two criteria which people use. One, I was trained in the UK, so I used the Trulovitz criteria, which is in Oxford, and that's a way of classifying how severe the disease is. And then there is the Mayo score for UC. So you can use either of them or both of them. So in mild disease, we have ASA compounds, fairly easily available. Some of them are cheap, but others are fairly costly. And the ASA compounds they come in long and short acting. Now you even get 1.2 grams, don't forget. It eases the pill burden load. You have enemas and suppositories. All of them are available in Kenya. Then you have steroids, oral, intravenous, rectal. Rectal comes in suppositories and enemas. We have them at Aga Khan solely because we have quite a lot of patients and we use them depending on where the colitis is. Measure your sugars and pressures and potassiums and electrolytes and check for osteoporosis, in other words, DEXA scan. So if the patient relapses and does not respond to steroids, consider thiopurines. Azathioprine is most commonly used. Then you have 6-MPs and thioguanines. Ideally, we should measure TPMT levels, but they're expensive and they take time to come back. So start with a small dose because it can cause nausea, and up the dose. Check for marrow liver toxicity initially, but then subsequently you can just check every 3 months. If there's severe pain, consider pancreatitis. Do not reintroduce thiopurines then. 6-MPs, you give with folic acid. Risk of cirrhosis is very low, but if the transaminases go by ×2, you can stop it. Check for interstitial pneumonitis, again, reversible. It is teratogenic, so do not use in pregnancy, and make sure the patients are on a contraceptive pill, and monitor your bloods. So we come to the biologic and the small molecules. So the TNF-alphas are the ones that we have had for a while. All three are available in Kenya: infliximab, golimumab, and adalimumab. Then we have the interleukins, which are the ustekinumab, which can be imported on named patient basis, and the anti-integrins vedolizumab, which I have patients on all of them, and we can get them on named patient basis. The other one is tofacitinib, which is more for rheumatologists, and we are learning from rheumatologists. Only problem is there is not much data on pregnancy. Then some of the slightly newer ones, the ozanimobs, which are sphingosine phosphate inhibitors, and the biosimilars. In other words, they act like it, but they need licensing. So these two, infliximab and adalimumab, have been approved by FDA. South Africa is trying to get it in Africa. So I'm hoping we will be the next once they succeed. So in other words, the costs are low, work same, they passed the test. So moderate to severe conditions, start on infliximab, usually expensive for our conditions, adalimumab, golimumab, vedolizumab, and tofacitinib, and ustekinumab, all these quite difficult names. Infliximab is the most studied because it's been there since 1998. It is superior to adalimumab, but it has to be used in combination with azathioprine. It disrupts the inflammation and downregulates the inflammatory cytokines. It reduces lymphocyte count and induces apoptosis of the TNF-producing cells. So you give an induction course and then slowly at a slightly increased frequency, and then you're at 2-monthly interval. Can be used in pregnancy, children over 6 years old. Because it's been an old drug, we can use it, but it's, as I said, it's expensive. Just be cautious in some patients: diabetics, active infections, seizures, COPD, heart failures, and rule out TB, rule out TB, can't emphasize more. So as I mentioned, over 6 years of age, you can use it. It's been approved. And if you don't respond, don't use the same drug. Don't use the same drug. Use another class. So go to Vedo, go to ustekinumab, don't use the same compound. Generally, Vedo and ustekinumab is used to reduce remission. And our aim is to reduce clinical remission. So there are 2 ways you remit. One is clinical, they feel better, which is great. CRPs are coming down, that's great, but we need an endoscopic remission as well. So you may need to do more colonoscopies just to ensure remission, and patients hate it. They hate colonoscopies, but you know, it's a one final way of knowing that they're in remission. The good thing is ustekinumab is given subcutaneously and tofacitinib is orally. So when you get severe patients, you can use IV steroids, hydrocortisone enemas, antibiotics, probiotics. Ideally, you should respond within 3 days. You can go into 5 days if the CRPs are gently coming down. Please have a surgeon because on standby in case the patient goes into fulminating colitis. And you can have a bridge therapy. Patient responded very well. You can use cyclosporine or infliximab. Actually, I've used cyclosporine in my patients with bridge therapy, and they've done very well. And I managed to tide them over, and eventually died of something else. And you can add in azathioprine and check your electrolytes. Yeah. So upper GI Crohn's in children, you can just use PPI, steroids, and thiopurines. In structuring disease, where usually it's terminal ileum and all, use elemental diet, not high fiber, balloon dilatations, biologics, and surgery only for structuroplasty. Drain the abscesses, sit on stitches. You're not going to be very aggressive with this. Stoma and proctectomy to remove the fecal material from the anal site, give them rest. If the terminal ileum is removed, use bile acid chelanes. Think about bacterial overgrowth and discourage smoking, especially in Crohn's. Look for crow infections everywhere, immunize, make sure the patients are immunized. But there are some vaccinations you may not be able to give once you're on medications. Serology, again, we do the VZV. Unfortunately, we don't have VZV immunization here in Kenya. We really need to get it because we are seeing patients with herpes zoster, which is a horrible condition. As I said, influenza vaccines, make sure, because you don't want these patients to get sick. Herpes zoster, polio, typhoid is contraindicated. Do cervical screening and look for depression. These patients get depressed. I mean, you can imagine the condition where you're going to the washroom, you're not happy. So look for depression in these people. This is another thing you really need to address. Fecal transplantation has been done. Now it's available commercially in tablets. Complementary therapy, I'm mentioning cannabis, but it's illegal in Kenya. Good quality colonoscopy. Good quality colonoscopy. BISO score 9, in other words, to make sure that there is no fecal material, you're managing to clean out, take time to do the colonoscopy. You can add on with online visits, diary, and primary care physicians. So look after the colon. It's precious. It's important in our day-to-day setup. I mean, it's not nice to have a bag. Thank you.
Thank you very much, Smita Divani, for a nice presentation. A difficult subject for most of us, but you've made it very, very simple and clear to follow. And like she says, it's no longer a disease of the West. I know most of us, when we were training in the early days, you just know the name, don't bother to know anything more. But right now, it's every other patient comes with something like that. So thank you very much. Just to remind you, please note your questions or concerns. We'll have a Q&A at the end of all the presentations. It's now my pleasure to introduce the next speakers. They're going to co-share the podium. Dr. Sajni Babari and Dr. Farida Kaitanyi. Dr. Sajni is a fellow at the University of Nairobi World Gastro Organization School, training to be a gastroenterologist. Dr. Farida is a consultant physician, past graduate diploma gastroenterology, and right now she's a WGO fellow again at the University of Nairobi. Welcome. I don't know who's going to start first.
So good morning, everyone. It's nice to be back in Eldoret. This was my town for many years doing undergraduate. The topic we are discussing today with Dr. Sajni is GI screening of screening for GI malignancies. It's a rather broad topic. I'm gonna choose specifically esophageal cancer because I think that's a very relevant topic for our population. I think it's difficult to cover the other malignancies like gastric cancer, which is less common compared to esophageal cancer. So why I think we should pay attention to esophageal cancer is, of course, Kenya is in the high incidence region and is part of Africa's esophageal cancer corridor, which starts from Ethiopia down to Kenya, Zambia, Zimbabwe, down to South Africa. So, and specifically, even within Kenya itself, we know that there are hotspots for esophageal cancer, the central Kenya region, and then the western Kenya area, including Eldoret, going all the way to Kisumu. Those are the hotspots. And then also, of course, like I said, we are part of the esophageal cancer corridor. And Kenya has one of the highest incidences of esophageal cancer, specifically squamous cell worldwide, with an incidence of about 17 per 100,000. And also, what is notable with esophageal cancer in Kenya is that it has the highest percentage of young patients. Up to 11% of those patients with squamous cell carcinoma are patients less than 30 years. I'm not going to focus on adenocarcinoma because adenocarcinoma is not the most prevalent type. Ours is squamous cell carcinoma, and it accounts for more than 90% of all esophageal cancer cases. And most of the time, by the time we are diagnosing esophageal cancer in Kenya, it's end stage, and we don't have screening guidelines actually. And the rest of the world is also not necessarily focusing on developing screening guidelines for esophageal cancer. Why? Because in the West, they are seeing a very significant decline in the cases of esophageal cancer. They are smoking less alcohol intake, and other than parts of Asia like China and now Kenya, really it's not their problem anymore, so they're not focusing on it. And once we diagnose esophageal cancer late, most of our patients have a very low survival rate of 19%, and most of our, like I said, most of the time, by the time we're diagnosing esophageal cancer, it's late. We don't cure them, we're usually palliating them. And the gold standard for diagnosis at present is endoscopy and histopathology. So why do we think we have a high incidence of esophageal cancer in Kenya? I'll just briefly mention the traditional risk factors in the rest of the world, like smoking, alcohol intake, certain conditions like achalasia, which of course if you have, you need screening every 2 to 3 years for esophageal cancer. Patients who have breast cancer and get radiation, those are patients who have a high risk for esophageal cancer. Patients with head and neck tumors, those ones you need to pay attention to them, because all patients with head and neck tumors, up to 10 to 15% of them develop esophageal cancer. So make a mental note for that. But in Kenya, what is specifically has been thought to be found to be maybe contributing to the higher incidence is hot drinks. A study was done actually at MTRH, which showed a high association between hot drink and increased risk of developing cancer. And other studies done in Tanzania, northern Iran, and southern China have shown that these hot drinks causing thermal injury to the esophagus have been associated with an increased risk of esophageal cancer. There have been some questions about HPV, which is highly prevalent in women in Kenya, being a contributing factor, but the studies that have been done in Kenya have shown mixed results, and there's no clear association. But what has been consistently demonstrated is the way the nutritional deficiencies and food preparations. As our diets have changed over time, and mostly shifting to things like from sorghum to maize meal, and from the traditional vegetables to maybe cabbage and skuma wiki. This esophageal cancer corridor has been shown to the diets, these newer diets, specifically high rich in maize meal, they have been shown to have micronutrient deficiencies, specifically zinc and selenium, which have been associated with a higher prevalence of malignancy. And then alcohol and acetaldehyde. There's a small study that was done in Tenwek. I'm a Kalenjin, so I like Mursik. I was a bit discouraged to see that study. They looked at, I think, 9 samples of the traditional milk, Mursik, and they found that there was high content of acetaldehyde, which is, of course, a risk factor for esophageal cancer. And then also when they looked at busa, the busa, the traditional alcohol brew, high content of aflatoxins. So those could be some of the things that could be contributing to this higher incidence of esophageal cancer. Then, of course, we saw the very young patients, and also multiple studies which have been done that have shown a genetic, families pulling together and having a higher risk of esophageal cancer. So these are some of the pointers, some of the things we need to think about. Why is squamous cell esophageal cancer an issue in our population? So just to go to some of the things we can do to pick up these malignancies early and hopefully intervene before we have that very poor survival rate. For those who do endoscopies or who are familiar with endoscopies, you can see this, I don't know where the pointer, sorry. But you can see that protruding lesion. This is typically what we see, unfortunately. And these patients are not going to survive. So if we're going to be picking our patients at this stage, then we're going to be doing them some disservice. But there are simple things that we can do as doctors who provide endoscopic services that can lead to early detection of these malignancies and hopefully improve their survival. One is narrowband imaging. I'll give you a little bit of detail on that, and chromoendoscopy. Chromoendoscopy is not something new. The gynecologists use it for cervical cancer screening all the time. Let me start with chromoendoscopy. Chromoendoscopy is when we use topical stains or pigments to improve tissue localization, characterization, or diagnosis during endoscopy. For squamous cell carcinoma, detecting early squamous cell carcinoma or detecting dysplasia, we can use Lugol's iodine. It's a very simple thing to do. And the principles behind this is that Lugol's iodine is usually taken up by the squamous epithelium due to the glycogen stores within the cells. But in inflammatory condition, dysplasia, malignancies, those cells are depleted of glycogen, and so they become unstained. So you can see this is what would typically look like a normal esophagus under white light imaging. You won't pick up any lesion in this. But when you do the same patient, when you do Lugol's iodine, you spray the Lugol's in the esophagus, you can see the unstained areas. This, I don't know where the pointer is. Sorry. Yeah, the unstained areas, the whitish areas at 37 and 28 centimeters. Similarly to this, you may not pick up the lesion, but on Lugol's iodine staining, the lesion becomes very clear. And the problem with Lugol's staining is that you might, because it picks up inflammatory conditions, you may miss it. So one other thing as I finish is something called narrowband imaging. This is very simple because it's just on the click of a button. During the endoscopy, there's a button you click and you apply this optical filter that filters blue and green light, and you can be able to see the abnormal vessels in malignant lesions. So like in this lesion here, this, the first slide there is white light. This is narrowband imaging, and those brownish areas are the areas that are early squamous cell carcinoma. And this is something we should apply as doctors doing endoscopy, similarly to that. And once you've diagnosed on narrowband imaging, you can actually be able to detect that the disease is early enough, and you can do endoscopic mucosal resection, remove the tumor. So in summary, I think we should apply these newer techniques, chromoendoscopy, and all doctors doing endoscopy should use the narrowband imaging as they remove their scopes so that they can detect these early esophageal lesions and we can save our patients. Thank you very much.
Good morning, everyone. I'm just going to get started. So today my topic is on lower GI screening. We're going to look at mainly the what is screening, why we screen, and how to screen.
To fill up our time, maybe we can take a few questions from Farida. Thank you very much, Farida, for a nice presentation. I think all of us must be familiar. Sure, we've had several patients with squamous cell esophageal cancer. Yes, somebody near me.
Thank you, Professor Some. My question goes to Dr. Devani, actually. So I wanted to ask about the steroid resistance treatment in UC. What time frame would you say steroid resistance? So is it 8 weeks, 12 weeks, 24 weeks? How long from your experience? Thank you.
Okay. Before we used to say two steroid inductions and we use an alternative. But now, if you fail one, so in other words, if they respond, there are two things. One, they never respond, and the second block is people who respond, but as soon as you reduce, it goes up. So these are the patients who are actually being monitored, and you're doing that, whatever, 40 weeks or 60 milligrams, and you're gradually winding them down. And then you see at 40, they're again getting symptomatic. 30, they're getting symptomatic. Start using an alternative, one of the thiopurines. So these are the patients where you actually have a lower threshold. But now there are also different things coming into play where they are saying go straight for biologics. We can't afford those. But deep ulcers, fulminating colitis, younger age group, start using biologics and induce remission. So what we used to use, things are changing as well in the last 3-4 years. I hope I can answer your question.
Thank you. Are you okay, Miriam? Where are the girls?
Jonathan Walla here. Thanks, Dr. Farida, for such an enlightening presentation. There are hundreds of OGDs that are done every month in this country. Lugol's iodine is very cheap. Shouldn't it be mandatory that all OGDs should have Lugol's iodine staining as part of the procedure, part of the screening? Thank you.
Thank you. Is it? Okay. We'll put your questions on hold until the end of the session, since our next presenter is ready with her slides.
Thank you,
Karibu
Prof.
Sajne.
Thank you, Prof. So like I said, we're going to look at what screening is, who to screen, and how to go about it. So colorectal cancer is a type of cancer that affects the colon and or the rectum, and screening is trying to look for the cancer before the onset of symptoms. As per the WHO, colorectal cancer is the third most common cancer worldwide, accounting for approximately 10% of all cancers, and is the second leading cause of death. In Kenya, there's Globocan data from 2018 where they diagnosed over 1,300 cases of colon cancer, and then they had over 900 deaths from the same. The natural history of colon cancer is such that if we do screen, we can catch these patients much earlier, because it takes 5 to 10 years for a normal colon to get a small polyp and then become a larger polyp and eventually become cancer. So why screen? Colon cancer has high mortality, morbidity, high economical, emotional and physical burden. Majority are locally invasive or distant metastatic by the time we get to them. So screening is to prevent or delay the progression to overt cancer. And screening also allows for therapeutic intervention and treatment with good clinical outcomes. Who do we screen? So we either group them into high risk and average risk, or modifiable and non-modifiable. The high risk patients are the ones that we really need to look out for. These are the ones with a personal history of cancer or a certain type of polyp, a family history of colorectal cancer, a personal history of inflammatory bowel disease, what Dr. Devani had just spoken about, a confirmed or suspected hereditary colorectal cancer syndrome, a personal history of getting radiation to the abdomen or the pelvis area. They can also be divided into modifiable and non-modifiable. Non-modifiable being the ones we've already discussed as high risk, and then on top of that we add the male, gender, and age over 45. Modifiable risks are, amongst others, the intake of red meats, physical inactivity, poor diet, alcohol intake, tobacco use, and obesity. How do we screen? So we have two modalities. There's the stool-based test and the visualization. Visualization is either endoscopic or by CT scans. We'll look into the stool-based test. So first, we normally send our patients for something we call FIT. We look into our lab orders and we tick it. What is it? So the FIT test is looking at the hemoglobin in the stool. It has a high specificity between 60 to 80 and a similar sensitivity. However, it is less sensitive for right-sided colon cancers, does not require a change of diet or any restriction in medication that the patient is on. Guaic-based fecal occult blood test identifies hemoglobin, but it involves a peroxidase reaction. So this does require a dietary restriction of excessive vitamin C and red meat to avoid false positive or negative results. It has a sensitivity between 31 to 70% and a higher specificity between 87 to 98%. The last stool test is a combination of the FIT and DNA. So this combines looking for DNA mutations in the stool that are suggestive of colorectal cancer and the FIT test. This, we don't have major randomized trials for the same, but is known to have more sensitivity and specificity. The good thing about the stool test is that they are non-invasive, cheaper, patients are more compliant to doing it, do not require bowel prep for the same. However, for the first two stool tests, the problem is adenomas are not constantly bleeding. There's intermittent bleeding. So sometimes you get your false negatives for the same reason. We move on to colonoscopy. Colonoscopy is the definitive test for detection of precancerous adenomas and colorectal cancer. It allows direct visualization all the way from the rectum up till the terminal ileum if done well. More sensitive for left-sided versus right-sided, raised versus flat, and large versus small adenomas. It requires sedation, good bowel prep, and requires withholding certain medications if therapeutic is anticipated. Sigmoidoscopy, similar to colonoscopy, but only allows visualization till the splenic flexure, so only for left-sided lesions. Now this obviously we miss out on everything going on the right, and it has been postulated that right-sided cancers are more difficult, they're more difficult to treat, more common in females. So when we do an endoscopy, what are we looking for? It's very similar to any lesion, like a lymph node. If we were to do a general lymph node, what would we be looking for? We're trying to see, is it friable, is it necrotic, is it firm, tender? Those are the things that make us think about cancer. Then we have colon capsule endoscopy, done in very few centers in our country, but it's currently only approved for those patients with incomplete colonoscopy for whatever reason. It does require a bowel prep, but no sedation or withholding of any medications, and does not allow any interventions. Has good sensitivity and specificity for adenoma detection. Radiologic visualization, we have the computed tomography, colonography. So this involves radiation exposure, requires bowel prep, does not allow any therapeutic sedation, does not allow any therapeutic intervention, and no sedation is required. It allows visualization of the entire colon. Sensitivity for large adenomas is 67 to 94%, with a good specificity over 90%. So this figure pretty much summarizes what we've been talking about. And as you can see, colonoscopy at the far end has a high sensitivity and specificity, starting from the smaller adenomas going all the way to colorectal cancer. Our stool tests have much less sensitivity and specificity for the smaller adenomas. So guidelines, does everyone need a colonoscopy? Does everyone need a stool test? Does anyone need anything at all? So the Kenyan guideline recommendation is to risk stratify, what we said, average risk and then high risk. Once we've done that, so average risk, age over 45, asymptomatic, no family history. You start with the screening at 45 years. You start with a stool test and then offer colonoscopy. If colonoscopy is normal, then repeat every 10 years. If you don't have colonoscopy, you could do sigmoidoscopy every 5 years. Increased risk are those patients with a first degree relative, less than 50 years of age, or an advanced adenoma in less than 50 years of age. These are patients that need 10-year colonoscopy from the age of 40, or 10 years earlier than the youngest relative. So if their youngest relative had colorectal cancer at the age of 30, your patient starts colonoscopies at the age of 20. Then we have persons with multiple first-degree relatives or others who are diagnosed with colorectal cancer above the age of 50. So you need 5-year colonoscopy from the age of 50, or 10 years from the youngest relative. High risk are the ones with the hereditary predispositions, the inflammatory bowel disease. These patients need genetic counseling and testing. Colonoscopy done even as early as the age of 10 for familial adenomas polypomatosis. When do we stop? We started at either 40 or 45, so when do we stop? If you have prior negative screening, especially by colonoscopy, at the age of 75, or if you have an estimated life expectancy less than 10 years, you can stop. If you've never done a colonoscopy, then up till the age of 85, you go on screening. This is adapted from the Japanese guidelines and pretty much tells us when to repeat. So if you have smaller adenomas, 2 or less, then 3 to 5 years. If they're 3 to 9, then 3 years. If you have an overt neoplasia, then you need surveillance in 1 year. Those were my references. Thank you.
Thank you very much, Dr. Apabari. Let's give her a hand. Yeah, my name is Dr. Eric Murunga, and I'm assisting Professor Some in chairing this session. So welcome again, all of you. For the next session, those of you remember 2 nights ago, we had episode 1 of H. pylori, and we've been promising episode 2, which was supposed to be yesterday evening, but it's going to be today, starting now. As you remember, episode 1 had all the elements of a thriller. There was drama, and a lot of interesting questions. Some were referred to today. But on that day, we had Professor Some, and she helped us to deflect some of them. I'm glad Professor Loach is here. And now today we have Professor Lule also coming. And I'm just going to introduce him. He's going to chair this coming session, and he'll introduce the speakers. But in brief, I think all of us know Professor Lule. He has been a mentor, not only to the gastroenterologists, but I believe to most of us in this room, having been a professor at the University of Nairobi for many years, from when we were students. He held our hands, and he is one of the people who definitely inspired some of us to go into the field of gastroenterology. So it's a great honor and privilege for me to invite Professor Lule to come over on stage. Thank you very much. Let's welcome him.
Thank you very much, Eric, for those very nice words. I think I'll not sit down before I comment on this. I will not start our talk before I comment something. I think that was excellent, an excellent approach to a very, very difficult problem, screening. I liked your talks, and keep it up. As we move into the other aspects of the GI, which we would have done yesterday, because of time, I'll start by introducing the speaker so that we get into the nitty-gritty of everything. Our next speaker is none other than Linda Gathara. Linda is very, very well known in the field of gastroenterology now. She trained in the University of Nairobi for her MBCHB and moved on to South Africa after the MMed, and where she did a lot of gastroenterology training. She excelled a lot. I know she's a very good doctor because she worked with me either as an undergraduate, a postgraduate, and as a fellow. She's done very well. She has published a lot of work, especially in the field she's going to address, that is gastroesophageal reflux disease. She has published an excellent paper, which was even recognized by the World Gastroenterology Organization. So Linda, come up and share some of the things that you published, so that may as well gain.
Thank you, Prof. So welcome to episode 2, and we'll be looking at the new era in gut management. Okay, gastroesophageal reflux disease is a common clinical problem affecting millions of people worldwide. It's about 50% of the cases we receive as gastroenterologists. There's a Montreal definition, which defines GERD as a condition that develops when reflux of stomach contents causes troublesome symptoms and complications. Its typical manifestations are heartburn and regurgitation because it's gastroesophageal reflux. And this is different from dyspepsia, which is gastroduodenal. So in dyspepsia, you have things like bloating, abdominal pain, and the likes. So it's often chronic and relapsing, and it can further be classified into NAN, that is non-erosive reflux disease, erosive esophagitis, and Barrett's esophagitis based on the mucosal findings that we find during endoscopy. Significant complications include stricture formation, esophageal cancer, and Barrett's. And there's also the economic burden because we get people coming to our offices many times and there's absent from work, and even the medication itself is very expensive. And due to increasing prevalence, its epidemiology has been a subject of growing interest. So looking at the global prevalence, It varies greatly all over the world, and we can see that Africa is conspicuously missing from the global epidemiological map. The lowest is in Asia, Eastern Asia, countries like Japan, followed by Australia, South America, and Europe, about 20%, and the rest. So the true incidence of GERD is largely unknown in many African populations, but its prevalence is believed to be increasing due to demographic, nutritional, and lifestyle transition. Some studies done in sub-Saharan Africa cited a negative correlation between H. pylori infection, which is normally acquired in childhood. It provided immunity against GERD. So there's physiologic and pathologic symptoms. Physiological is postprandial, short-lived, asymptomatic, and they are non-nocturnal symptoms. And in pathological GERD, you get the symptoms. You have the mucosal injury at endoscopy, and we also get the nocturnal symptoms. So the pathophysiology is complex, and it acquires an individual approach. But to be put simply, the primary barrier to the gastroesophageal reflux is the lower esophageal sphincter right here, and it normally works in conjunction with the diaphragm. If the barrier is disrupted, acid goes from the stomach to the esophagus. So the esophagus acts as a pump, propelling food forward through the lower esophageal sphincter, which acts as the valve. So there are various mechanisms of reflux. There could be an impaired lower esophageal function. Some people have a lax LES, hiatal hernia, when parts of the lower esophagus and the stomach are displaced upwards and you get reflux. Impaired esophageal mucosal defense against gastric contents. We know that the mucosa has structural and functional constituents that protect the esophagus from the gastric reflux. So when you have a lot of material refluxing, there is the change of the squamous to columnar, and this is the genesis of Barrett's, and we know Barrett's and GERD are precursor of esophageal adenocarcinoma. Then there's also defective esophageal peristalsis, delayed gastric emptying, which we see in diabetes and other conditions. So the risk factors are many: obesity, caffeine, spicy foods, medications, pregnancy, alcohol and tobacco, anxiety, lack of regular exercise, and even tight clothing. So clinical manifestations, we have dysphagia, which is difficulty in swallowing, and other symptoms include chest pain, like we said, heartburn and regurgitation, water brush, that's the bitter taste that people develop in the mouth, globus sensation. Most of our patients also present to the ENT, odynophagia and nausea, and extraesophageal manifestations include asthma, laryngitis, and chronic cough. In fact, sometimes we get referrals from chest physicians. So a diagnosis of GERD is clinical, it's not endoscopic. Based on the symptoms that the patient has, we even have questionnaires on that. And if classic symptoms of heartburn and regurgitation exist in the absence of alarm symptoms, we'll talk about it later, the diagnosis of GERD can be made clinically and treatment can be initiated. So most of the time we do the trial of PPI, and if the patient responds, that is a confirmation of GERD. And the main tests used when GERD is suspected are esophageal pH manometry, endoscopy, and manometry. Okay, so that's me. This is Kenyatta at our endoscopy unit. Endoscopy is indicated in patients with alarm symptoms like dysphagia, odynophagia, bleeding, anemia, weight loss, and recurrent vomiting and early satiety. And we use the Los Angeles classification tool based on the number of mucosal breakages. And this is actually the modified Los Angeles criteria, which includes grade M here, because in Japan they see a lot of minimal changes. And this is during endoscopy, so it goes from grade A through to grade D. So treatment, although GERD is a disorder of motility, the therapy of reflux disease is aimed at reducing acidity in order to decrease esophageal mucosal injury like we have seen there. So the lifestyle modifications may be effective in decreasing or eliminating GERD symptoms, but majority of the patients require pharmacologic therapy. And in fact, so many end up being on long-term PPI treatment. And our goals of therapy are, of course, symptomatic relief, to heal the esophagitis, and to avoid complications. So the pharmacological treatment has changed drastically over the years. H2 antagonists were developed in the 1970s. Prof. Lule did a lot of studies on H2 receptor antagonists. Then the PPIs came in the 80s, and then we now have the potassium competitive acid blockers, which have been developed, but they have been in use since 2015 in Japan. So the antacids are over-the-counter acid suppressants, and antacids, the initial therapy. In most chemists, we see people, especially after a night out, they come and then they ask for antacids, and approximately 1/3 of the patients with heartburn-related symptoms use at least twice weekly, and they are more effective than placebo. Then we have the H2 receptor antagonists. We know all these things which competitively block histamine receptors. We have cimetidine, famotidine, ranitidine. And then we have the PPIs which inhibit the sodium-potassium ATPase. We have esomeprazole, omeprazole, lansoprazole, rapiprazole. Can I have some water? Water. Sorry. So we have the esomeprazole, omeprazole, lansoprazole, and pantoprazole. And then now we have the potassium competitive acid blockers. And we have vonoprazan fumarate, which is the first in class competitive potassium competitive acid blocker that has been available in the market in Japan since 2015. It was only approved in the US last year. And it inhibits the sodium-potassium ATPase in a reversible and a potassium competitive manner. The PPIs also work, but in a different matter. These ones, they act on the potassium channel, and they bind ionically, and the PPIs, it's covalently. And you can see here, it has a long plasma half-life. It's stable in acid and slow dissociation rate, and has a rapid onset of action, which is sustained. So the effectiveness of medical therapies for GERD, lifestyle modifications, the response is about 20%, to H2 receptors about 50%, single dose PPI is about 80%, and in double dose PPI goes up to 100%. So we also have anti-reflux surgery, and this is when failed medical management, and the patients, sometimes they prefer this, and even in patients who have complications of GERD. And the medical complications attributable to a large hiatal hernia. You find a patient with like grade 3 and grade 4 with recurrent symptoms. These patients go for surgeries. Normally they do the LNF. Then the aims are to reduce the hiatal hernia, repair the diaphragm, strengthen the gastroesophageal junction, and then also to strengthen the anti-reflux barrier via the gastric wrap. And it's at least 75 to 90% effective. Then we also have endoscopic therapy, which is new. We have the ARMS procedure. We have radiofrequency application to the lower esophageal function to increase the tone, and therefore it's able to contract. The Stretter procedure, and then we also have suture ligation of the cardia, and we also have some mucosal implantation of inert material. And this is what we mean. In the first, this is the anti-reflux mucosal ablation. This is radiofrequency. And then the next one is anti-reflux mucosectomy, and there's also anti-reflux mucoplasty. Thank you.
As I promised you, it has turned out to be excellent. And I could tell that by you been clapping before I asked you. Could you clap again? Because I think she did it very well. It's a very wide topic, and she covered all the aspects. We'll not take questions now, Linda. We will wait for the next speaker. next speaker is none other than Dr. Ajua Akeng. Dr. Ajua, I've also known him since he was a medical student at Kenyatta National Hospital. He was unfortunate enough to rotate through my unit severally, that was 7D, both as an undergraduate and as a postgraduate. And I think that's why he liked gastroenterology. We are surprised when he joined us and said, I want to be a fellow in gastro. And he trained in Kenyatta and did very well. He now works as the Chief of Gastroenterology, Aga Khan University Hospital in Nairobi. He's very active both in the Kenya Association of Physicians and also in our society, Gastroenterology Society of Kenya. And he has promised me that within about 2 or 3 months, we'll be coming up with a booklet on guidelines for Helicobacter pylori therapy in Kenya. Welcome, okay.
Hi, guys. Could I have this on, please? Good. I prefer this. All right, so good morning, everybody. Thank you, Prof. Lule, for the introduction. Thanks, KP Eldoret, for having us over. It's good to be back here after a number of years. The town has really grown. So good morning, colleagues, and welcome to our presentation for the morning. So that's my name, and those are my credentials. And no, I did not go to Alliance, in case you were wondering. So those are my disclosures. Yes, on International Women's Day, I have to admit that my wife did play a role in my coming to Eldoret, both in cash and kind. So that was me when I was told. Initially, the program said I had about 5 minutes for an H. pylori presentation, and that was the look on my face. But then I remembered I was KAP Vice Chair, and this is Africa, and corruption is our business. So I am free to take a bit more time than allocated, and I'm sure you'll all understand. So I will take you briefly through the principles and practices of H. pylori diagnosis and management. It's going to be a very quick but heavy number of slides. So I think the takeaway message for today is very, very important, and you'll probably see why later on when I go to the summary. So patient selection is very, very critical because not all abdominal pain is H. pylori, and that seems to be a big issue we're having all over the country at the moment. The choice of test is very, very important as well. And finally, you need to try and aim to succeed at the first attempt of treating H. pylori. And how do you do that? By knowing your local resistance patterns and taking a very, very good history of your patient's antibiotic use. We need to be antibiotic stewards in Kenya and in Africa. If not, in the next 30, 40 years, we'll all die of sepsis because our antibiotics will become quite useless. And the reason will be we've been chasing after H. pylori. So who do you test? These are the recommendations of the 5th Maastricht-Florence consensus report. Maastricht and Florence guys, if you're wondering who those fellows are, that's just a group of guys who are a little bit elderly in the profession, who sit together, enjoy pizzas in Italy, and decide and tell us, okay, this is what we have decided with. So dyspepsia, patients who you should test for H. pylori are patients who have dyspepsia. Whether you have peptic ulcer disease, gastritis, you're suspecting a gastric cancer, or you have an unexplained iron deficiency anemia. Those are the only people who ideally you should be looking for H. pylori in. Our prevalence rate in Africa is 65% and above. Chances are if you test a patient for H. pylori, just for the sake of it, you will find it anyway. Locally, what's my take? I agree with the guys who were eating pizzas in Florence. You should only test for people who have dyspeptic features only. Do not chase after H. pylori if a patient does not have dyspepsia. Universal testing in Kenya, the reason why I say we should not chase after H. pylori is this. Our gastric carcinoma rates are steady, if not dropping to an extent. The high risk which is associated with H. pylori in the West really, frankly, does not exist in our environment. Why that's the case, we might never know. But at the moment, our risk for gastric carcinoma is not as bad as that in the West. Hence the reason why I say we should not take their guidelines where they are chasing after H. pylori and try to inculcate it in our setup. So what's a quick recap on dyspepsia? What's dyspepsia? Basically, this is episodic, recurrent, persistent abdominal pain or discomfort, or any other symptom that is referable to the upper alimentary tract. This is excluding jaundice. So your symptoms in this case include what? Abdominal pain or discomfort, heartburn, anorexia, nausea, vomiting, flatulence, or air eradication. So please, these guys are not the people who you should be checking for H. pylori on. These are your guys who come to the clinic and when you ask them about the history, they tell you that their problems began when they were born. No. Look for guys who have specific and actual symptoms of dyspepsia and test them for H. pylori. So how do we test for H. pylori? My colleague Dr. Murunga, who's our chair for GSK, he did this the other day, so I won't go through it. The only thing I'll probably highlight is the most important test here are the antigen tests, if you're talking about non-invasive tests. The stool antigen test has a good sensitivity, good specificity, so too does the urea breath test. Those are probably the only two which I will advise us to use. The antibody test, frankly speaking, unless we are screening a population, which I said we shouldn't do anyway, is probably of no value in Kenya and in Africa. Do not use the antibody test, especially in our setup where we have been on antibiotics severally, people have been treated several times. It's basically worthless. Discard that test. For those of you who are businessmen, knock that test out of your laboratories going forward. Do not use the antibody test. How do we test? How do we treat, for H. pylori? Now, this is very, very important. Choice of the first-line therapy regime will depend on the following. What are the local resistance rates to the flagship antibiotics? Flagship antibiotics here for the longest time has been your clarithromycin and your Flagyl. What the advice is if the resistance rates are more than 15% in your region, that basically renders the antibiotic molecule less effective, and you should ideally discard it. Is the patient treatment naive? That is extremely important. That's why your history is of a lot of value in H. pylori. It's not as simple as just saying epigastric pain, dyspepsia, now let me give you whatever antibiotic I choose. You have to be very, very careful and check on what the recent antibiotic history is of the patient. Adverse drug reactions to the various antibiotics also, of course, very important. You don't want to give guys stuff which they are allergic to. So at the present, where are we? First line in Kenya so far at the moment is amoxicillin clarithrol, your PPI, or Flagyl clarithrol on the PPI. Second line has been amoxicillin levo on your PPI, or your quadruple therapy, which consists of your Flagyl, tetra, your bismuth, or a PPI, or levo, tetra, bismuth, and a PPI. The quadruple therapy line at sometimes has been also considered third line, so to speak. And finally, you have the salvage therapy, which is your rifabutin-based therapy. So, in my opinion, our current guidelines are like bringing a knife to a gunfight, or in this case, this guy decided to bring a spoon to a gunfight. It will not work, basically, and you'll see how we got to where we are right now and why we need to change our current guidelines. So, wondering how we got here, and I also ask myself the same thing. At times I wonder how certain things get to where they get, and one of my biggest quandaries has been the one on the bottom right area. But it seems like he's going to do it again, which is very interesting. This is the biggest one. I really do wonder how Arsenal got onto that tree, but we all know how it ends, usually. So how did we get to where we are at the moment? So, this is a study looking at the dispensing of antimicrobials in Kenya by Mwasi et al. In 2018. So they looked at 3 pharmacy sites in different socioeconomic zones. I think there was one in, they did Nairobi Hospital area, they did Buruburu area, and I can't remember the third one, I think Ngong. And they wanted to look at the extent of self-medication of antibiotics and dispensing practices in Kenya. It was done over 3 months. And what they found was prescriptions checked for the validity by the chemist was at a whooping 96.9%. Very interesting stuff. That's the most important part of the slide. Who the prescribers were, not really important. The most commonly prescribed antibiotics, as usual, our penicillins were at the top. Those were the most commonly prescribed antibiotics. So, all looks very nice and rosy. However, as we all know, kwa grao vitu ni tofauti. So Sinovet looked at 70% of 203 pharmacies in 8 provinces back then. That was in 2011, before we changed to the county system. And they realized that 70% of those chemists did not require actually a prescription before before giving you an antibiotic. And this is probably the more likely condition rather than what the study said. So I'll take you through what they call a timeline of resistance. So this is a study which was done by Luailume and Professor Ogutu in 2005, looking at susceptibility pattern of H. pylori in patients with dyspepsia at KNH. And they realized that all isolated H. pylori organisms were resistant to metronidazole, 100% resistant. Susceptibility of the other issues was 93.6%. At the time, clarithromycin was still quite good. Amoxil was quite sensitive as well. Tetracycline was actually very good. Flagyl was essentially useless. We took a number of years later. This was Dr. Devani at Aga Khan. They looked at H. pylori prevalence and antibiotic susceptibility among Kenyans at Aga Khan. Sensitivity of clarithromycin at the time was quite good, but you have to remember also socioeconomic zones are a little bit different. Clarithromycin was quite sensitive. Metronidazole was actually very, very sensitive as well. And there was occasional resistance of about 4.6% to metronidazole. This is probably the most recent one which we have at the moment. There's another one which is ongoing. Kabuthi et al. At KNH, they looked at 2 sites, KNH and Nairobi Hospital, looking at susceptibility profile of H. pylori isolates. And this is what they found. Pointer might not be working. So, clarithromycin sensitivity, as you can look at the overall sensitivity, was 70.5%. Resistance, 13.2% resistance rate to clarithromycin as of 2020. Amoxicillin, 0% resistance. Metronidazole, 80.9% resistance. Your level, 2.9% resistance. Cipro, 2.9 as well. With that in mind, I think we are safe to say that metronidazole is probably absolutely worthless, and it should only be used probably for amoebiasis and other such GI infections, but not H. pylori entirely. So, where are we heading? So I happen to have been nominated to the task force we are doing an H. pylori guideline, and I'll be chairing that task force. Yeah, I keep on winning, as they say. All I do is win. Anyway, so I'll be chairing the task force, and this is what we plan to propose. So, in my opinion, I'm going to probably bring it up that we need to change the nomenclature for H. pylori therapy. The thing of first line, second line, and third line probably should be switched, and we need to stop that. The reason being, as I mentioned, a lot of things go into it all. You need to have a good history. You have to have an idea of the antibiotic use of the patient in the past, the recent past, etc., 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 and those who have been treated before. So we can no longer leave it as first line, second line, and third line. I think a clearer picture for nomenclature should be the following. In treatment naive, or those who have low antibiotic exposure, this is what you should do. You should start them on dual therapy plus a probiotic. Dual therapy basically means high doses of amoxil with vonoprazan, preferably, your PCAB, and you'll see why later on. High dose amoxil in this case is 1 gram TDS, or even up to 1 gram QID, I've seen some people doing. And also very high doses of your PPI or your PCAB. If the patient is treatment naive or low antibiotic exposed once more, the other thing you could do is you could use your triple therapy, which is amoxil plus clarithromycin plus vonoprazan or a PPI plus a probiotic. If they're allergic to penicillin, clarithromycin, levo, and vono should be your choice of antibiotic. The second group are those who had treatment failure or they've been highly exposed to antibiotics in the recent past. And this is what you should do. You should move to a level containing triple therapy. That is your amoxil levofloxacin plus your PCAB or your PPI plus a probiotic. The other option you have in that group is quadruple therapy, which is your amoxil, tetra, bismuth plus your PCAB or PPI, or amoxil levo bismuth plus your acid medication, or levo tetra bismuth plus your acid suppressing medication. Remember, all these things have to have a probiotic, and you'll see why also later. Salvage therapy will probably remain rifabutin plus amoxil plus your Vono. In this case, for the salvage therapy, please look at the highlighted area. For salvage therapy, you should completely avoid PPIs. You should completely avoid PPIs because of the cytochrome induction which the rifabutin causes. Of note, 14 days is the standard duration. Post-treatment testing is very, very important, and you should do the post-treatment testing 1 month after treatment and at least 2 weeks of PCABs. Note that all above treatments require high levels of acid suppression, and you'll see why as well. So how do you determine successful H. pylori eradication? Looking at the antibiotic resistance profile, pH of the gastric mucosa is also very, very important, and stability of the antibiotics within the gastric milieu are very, very key. And this is why it has been shown clearly that the better the acid suppression, the higher the pH of the gastric milieu, the better the success of treatment, as you can see from the graph. This also is evidence of that. So what is the rationale of the proposed dual therapy, which you saw in one of my first slides under my treatment guidelines? This is driven by 2 tenets. They need to reduce antibiotic resistance. They need to maintain gut microbiota. They need to reduce adverse effects profile, cost effectiveness, at the same time, high levels of eradication of H. pylori. So vonoprazan in dual and triple therapy regimens. Vonoprazan, we have discussed it quite clearly. It was developed in 2015 in Japan. How it works has been taken through already very well. It's an excellent drug. The reason why it works well is because it is not a prodrug. It is an active metabolite. Once you take it into your stomach, it acts immediately, and it lasts long in the stomach because it is quite resistant to the acid of the stomach. So it works faster, has a longer T half-life as well. So this is just evidence which Professor Loach would be very happy with. This is evidence now which takes us through the efficacy of these dual therapy regimes and triple therapy regimes using vonoprazan. In dual therapy, the evidence is clear. This was comparing high-dose dual therapy, sequential therapy, as well as clarithromycin triple therapy. And you can see vonoprazan dual therapy was equal and, in many cases, better than the other regimes which were using your normal PPIs. Vonoprazan dual therapy as well, several studies, most of them from Southeast Asia, because that's where the molecule came from initially. And all of them show clearly vonoprazan being at least non-inferior and in many cases superior in both dual and triple therapies. You can look at the slides later on, they will be shared. But the studies are many. Randomized control therapy, trials, together with observational trials as well. All are clear. As I mentioned, probiotics are very, very prominent in our treatment guidelines, and the reason is they are very good adjuncts for eradication of H. pylori, and they have several effects, both direct and indirect, in improving the eradication rates. And also of very high importance is they reduce the adverse effects which you get from the antibiotics which you're using, and because of that, they make completion of therapy more likely. So the evidence is there. 45 RCTs with over 7,000 patients, looking at specific probiotics in conjunction with your dual and triple therapy regimens. And the evidence was very, very good, that the eradication rates were much better when you included a probiotic into your treatment guidelines. It was quite impressive eradication rates and success rates using probiotics. Of note here, the reason why I brought these slides is because if you see on the second last column on your right, they are very, very specific probiotics. Not all probiotics are the same. That's probably a story for another day, which I'll probably present at another time. Something I'm very, very interested in. Not all probiotics are the same. Different probiotics have different effects and different uses. So you have to be careful which one you use in which condition, your IBS, etc., etc., etc. Many people just prescribe them very randomly because they're not aware, but probably will become more aware of this as the time goes by. So, finally, or last but one, should Africa chase after H. pylori? And that's where I have a big interest in. I am not very convinced, and I mentioned that at the beginning. Reason is our gastric cancer rates are steady, if not dropping. 2, H. pylori might actually be a good thing. There's evidence that it's immunoprotective of asthma. There was a study, I have not put it up on the slides, it's probably another story for another day, but it showed a 16% relative reduction in your risk of getting asthma as an adult if you actually had H. pylori colonization as a child. Do you need any more reasons why? Antibiotics damage our microbiome. We have a lot of patients who are coming in now in IBS and dysbiosis post-treatment for H. pylori. You've bashed them with antibiotics several times, first, second, third, fourth, fifth line. You damage their microbiome and they end up flipping into IBS. So that's the reason why we need to, if you want to treat the right person and treat it well at the right time. If not, you end up having issues with your microbiome. This is the loss of the normal microbiota post-antibiotic treatment, as you can see. And this is now the rise in opportunistic microbiota in your GI system after antibiotic use. So thank you all very much. And I think my time is up.
Thank you, Dr. Ajua, for a comprehensive exposure of Helicobacter pylori. Thank you. The questions, I think, will be many, but we are going to reserve the questions. You'll bear with me for the next 5 to 8 minutes. I'd like to introduce a speaker. Behind every successful man, there is a woman, and behind every successful company, I think there is a lady. So we'll hear from guest farmer who have actually hosted us. We want to hear Dr. Joan Wambui. Dr. Joan Wambui is the medical advisor to guest farmer. She trained not at the University of Nairobi, but at Kenyatta University. And she then later, after qualification, worked as a medical officer in Thika, and later on, no, he did internship in Thika, but worked with AAR as a medical officer. She's now the medical advisor to Gates Pharma. Welcome. We'll give you 80 minutes at the maximum. Thank you.
Good morning, everyone. My name is Dr. Wambui. Thank you so much. I'm very humbled to be in front of my seniors and my teachers. So we'll just go straight to the presentation. Much has been said by Dr. Gadara and Dr. Ajua. So we are here to try and understand what is this new era of PCABs, how are we comparing it to our PPIs, our lansoprazole, esomeprazole, and rabeprazole. As you can see, no pointer, okay. So as you can see, with different dosages, we can, being the bottom being vonoprazan, and we can pick maybe our most common PPI as esomeprazole at number 2. So in terms of the time for maximum plasma concentration, you can see with vonoprazan, it reaches up to 1.5 hours, you get your peak concentration, right? And we can look at our half-life. Let's just go straight to our last column here. As you can see, if you can compare to all the PPIs, vonoprazan with 10 and 20, the half-life is at least 6 hours. So in terms of pharmacokinetics, definitely vonoprazan is definitely standing out from our PPIs. And then I'm sure we have all faced the challenge with our patients in terms of, Doctor, I took breakfast in the morning and I forgot to swallow my esomeprazole, so I skipped that day, right? The compliance is very poor. So vonoprazan has come to change that. In terms of mealtime flexibility, it's completely insane. Such a clinical trial was done comparing the efficacy with meal and without meal, and you can see that the results are still constant. Dr. Gadara has talked about erosive esophagitis. So there was a research trial that was comparing vonoprazan and lansoprazole. So for all patients who had erosive esophagitis, the rate of healing was much, much better with vonoprazan, unlike our PPIs. In terms of our class C and D patients, definitely the healing rate as early as 2 weeks, we saw results from vonoprazan, unlike our lansoprazole. Same case here in terms of recurrence. The recurrence rate for vonoprazan was actually quite low compared to the lansoprazole that was commonly used and our PPIs in management of erosive esophagitis in all classes, A to D. So in terms of symptoms, we all know that our PPIs take a roughly estimate of between 3 to 4 days for the symptom relief to actually be at its maximum, right? So as you can see in both the graphs, the symptoms are relieved with vonoprazan as early as day 1. And throughout day 7, there was still a better rate of resolve of symptoms for all our patients, unlike the use of PPIs. In terms of H. pylori, Dr. Ria has talked quite a lot on that. So they tried, there was a research as well trying to compare, so is dual therapy better than triple therapy with using vonoprazan? And the studies actually indicated that it was equally as good, both dual and triple therapy. So safety and tolerability of vonoprazan. Another study showed that because both PPIs and PCABs, because both PPIs and PCABs actually reduce the acid production in our lining, so the side effects are actually similar. And in comparison to our PPIs, it was relatively, none of the drugs was superior or non-inferior than the other. So it gave the normal results that were demonstrated with our PPIs. So what about our special population? In terms of renal impairment and hepatic function, for the renal impairment, the studies have just been quite limited because it's a new drug since 2016, being Japan approved first line. Then we actually recommend you actually use it in care with patients who have CKD or renal failure. However, for our hepatic function, it has been shown that giving a low dose for a short duration of time is equally okay, and the patients will be fine. For our elderly patients, there was a new article actually that came out this year that showed that efficacy was okay, especially in patients who are PPI resistant. The elderly population with resistant PPI resistant GERD responded very, very well with vonoprazan, and in terms of the side effects, they were very limited. Our pediatric population, well, let's give it time for the trials to be done, but however, some trials demonstrated in Japan that age bracket between 12 to 15 years, high school goers, were given vonoprazan as first line in H. pylori management, and the safety was well tolerated. In pregnancy and lactation, definitely we'll have to use it in care, whether is benefit outweighing the risk. Yeah, and then for drug interactions, the drugs that inhibit the CYP3A4, we should use it in caution, because if they inhibit the CYP3A4, then definitely there will be a high concentration of vonoprazan. So in summary, our VonoPro, we can definitely see the benefits when compared to our PPIs in terms of our pH, yeah, and in terms of mealtime efficacy and the recurrence rate of erosive esophagitis. And a lot has been said about H. pylori eradication. So definitely this is a new era in terms of GERD and PUD and H. pylori management. Thank you so much. So today evening we'll actually be officially launching our vonoprazan molecule. We call it VonoPro, and we'll actually be doing this just during the gala dinner, the first hour, and the raffle tickets will be given then for people to actually win the amazing prizes that we have today. Thank you. Have a lovely morning.
Thank you very much. Let's give them a hand again. So we are continuing on with the gastroenterology session. And please bear with us. If you have questions, just write them down somewhere. At the end of it, all the presenters will come in front, and then the questions will be answered at that time. So right now, for the final part of the GI session, I would like to introduce the two speakers. We're going to have two speakers. There's Dr. Gladwell Carey and Dr. Kennedy Ondede. So just by way of brief introduction, Dr. Gladwell Carey, we work with her a lot. She's an oncologist based at the Nairobi Hospital. I remember her from undergraduate. She was one class behind me in medical school, and she moved very fast, did her M.Med at Nairobi University, then proceeded to the UK, where she qualified and got her fellowship in oncology, came back, started a very thriving practice, which she runs now from Nairobi Hospital, and she's also involved in charity work, including at Nakuru PGH, right next door. She's also the chairperson of the Division of Medicine at the Nairobi Hospital. So you can come over, and then as I introduce Dr. Ondede. Dr. Ondede is a surgeon. He has been awarded the OGW. He has done M.Med in surgery, and he's done his fellowship in India, including laparoscopic surgery and transplant and liver transplant surgery. So we're going to have a great time, and they're going to address the topics of colon cancer, medical management, surgical management. We've seen the screening. We've covered how to screen for esophageal cancer and colon cancer. Unfortunately, some people will still end up getting cancer. How do you deal with it? What are the current approaches in management of colon cancer? Thank you. Karibuni. Who goes first?
Thank you very much, Dr. Murunga. I'm glad to see quite a number of my colleagues. It's not a very common forum for surgeons, but we interact quite often with a good number of you. I'm glad to be given the opportunity to address this conference. The reason being, physicians are the owners of the patients. Surgeons, we are dished sparingly depending on whether the physician likes you or not. We respect you people. I come in peace from the surgical fraternity, and I hope by the end of this presentation, the peace will prevail. Okay. Carcinoma of the colon is a multi-pronged, is a disease that requires multi-pronged approach. As you've heard right from the presenters in the morning about the presumptive factors that are there in the beginning. Now we heard about H. pylori. It's a disease that requires stage-wise approach. Surgery is a big player in the center there, and we have topical issues which you need to look at, like how do you handle metastatic disease, and then what are the gray areas and the challenges we have when it comes to the interplay between physicians and surgeons, especially issues chemotherapy and more so neoadjuvant therapy, and then the other adjuncts of treatment like radiation, and then finally, of course, patient follow-up. This is the third commonest tumor in the world. Breast comes number 1, and colon around number 3 there. And it peaks around 60th decade. So already we know that systems are breaking down, and therefore we have many things to look at as we manage these patients. Of course, as Professor Lula will remind us, history, a thorough history is very important in picking out these patients. Sometimes the history is not obvious, and therefore we have to use tests like the fecal occult blood. Somebody has talked about it. Then more definitive ways of diagnosing colonoscopy, and it has to be colonoscopy completed, because you have had situations whereby colonoscopies are done and they hang somewhere in the center. I'm not opening the first war front, but we have had those challenges. And then, of course, we have supporting radiology and the relevant tumor markers that define the disease better. Once we have the biopsy, the histology confirmed, then the conundrum of treatment will proceed. What are the determinants of management, especially to us surgeons? There are those things we look at which are related to the tumor itself. What is the stage of this tumor? The type of surgery I'll do really is determined by the stage of the tumor. Where is it located? And location has to do with the blood supply, the lymphatics that I'm going to deal with when I'm confronting this tumor. Then we have things like, how has the patient presented? Is the patient one who is giving us time to prepare thoroughly, investigate thoroughly the way we want, make sure we consult adequately and come up with a very informed way and approach to treatment? Optimize this patient before we operate. Or the patient has come as an emergency. These scenarios play differently. Then there are patient factors, of course. Age, advancing age, has all those challenges that come with it, with the comorbidities and what have you. Performance of the status of the patient. The Eastern Cooperative Oncology Group has given us 5 stages, 0 to 5. ECOG. ECOG 0, of course, the best. ECOG 5, that is past tense. So we want a good performance status to get good outcomes. So when patients are very sick again, that means that we are going to have a challenge, and we really have to up our game. Are there comorbidities, diabetes, hypertension, renal disease, asthma, all these that come and challenge our way of managing? Because sometimes I've seen patients come with high blood sugar, and they're very obstructed. They're throwing up, electrolyte imbalance, and all this. Then we are arguing, do we first sort out the electrolytes, or we sort out the sugar first before we operate? So we start wondering, because the patient is throwing up. So it doesn't matter how much you're going to do. But sometimes you have to meet a middle ground, and that's where the multi-pronged attack to treatment comes in. We must have very good symbiosis between the surgeon and the physician to get good results. What are the molecular markers of this tumor? When we have tumor in the colon, of course, depending where it is and the stage, then we are going to decide, are we taking off the right colon? Are we taking off the transverse colon? Are we taking off the left colon? And now when you go to the rectum and sigmoid, the rectum area, when we start talking about anterior resection, is it high or low or very low? Okay? Tumors which are very close to the anal sphincter, playing around 2 centimeters there within the anal sphincter vicinity, are unlikely to be resected fully and to spare the sphincter. We'll have to remove the tumor segment plus the sphincter. So it's total abdominal resection of the tumor. But these other tumors, we're able to get them off, and then we reestablish the bowel continuity. So the type of surgery depends on where the tumor is and the stage of the tumor. Generally, stages 1 to 3, so to speak, are usually amenable to surgery. Stages 1 to 3 are normally amenable to surgery. Some stages 4 of tumor may be amenable to surgery, so we can still attack. More often than not, by the time we are dealing with stage 3 and 4, we are going to resect beyond the colon itself. We may resect the colon plus the spleen, the colon plus part of the stomach, colon plus gallbladder, colon and pancreas. We end up even doing Whipple's, depending on where this tumor is located. So possibility of doing en bloc resection, again, will depend on the how advanced local is that tumor. Of course, the intention of doing all these surgeries is, one, if we can get cure, that would be the best. Other circumstances, the tumor is inoperable, therefore we're just doing a palliative approach, probably just want to divert stool so that we relieve the obstruction, but we're not able to get the tumor out. In other instances, we do it so that we are able to help the pathology stage this tumor better so that we can now proceed to a definitive treatment knowing which stage of the tumor we're dealing with. In other situations, of course, then we decide whether the patient is going to benefit from neoadjuvant treatment or adjuvant treatment after we do the surgery. RO resection of tumor, of course, that is the best. That is curative. T1, T2 tumors, when we resect them, more often than not, that is enough. But depending on the tumor biology, occasionally then the oncologists come in and determine which way forward. I've alluded to how much and the extent we can go during surgery, but suffice it to say, more often than not, and these are almost standards of practice, when you're dealing with high tumors beyond the rectum, if I have a margin of 5 centimeters below the tumor, or a margin of 5 centimeters after the tumor, that is generally adequate. But if I'm dealing with very low tumors, then I have the leeway. We are allowed to staple because more often than not, you'll not be able to hand suture down there. We're able to staple tumors which are within 2 centimeters, above 2 centimeters of the anal sphincter. So there the margin is a bit accommodative, it's 2 centimeters. But in high tumors, 5 centimeters is acceptable. Lymph nodes, the pathologists want us to give them not less than 12 lymph nodes for it to be considered adequate harvesting of lymph nodes. And we not only harvest those lymph nodes, but we also look around the abdomen, and if you see anything else that is looking not very friendly, we get it out. At histology, if any of those lymph nodes will be rebiopsied and you found that the lymph node that remained behind is positive, then you change. If you are dealing with R1, you presume that now you are dealing with R2 resection. That means you didn't have very, very good margins. I'll not talk about chemotherapy there because my colleagues come and talk about it. One thing which we have found very difficult sometimes to convince colleagues about is the use of minimal access surgery, laparoscopy. The world is moving minimal, and the world is tending towards minimal access. In fact, they're now going to the robots so that the spaces we have to work within and the accuracy to detail is even much better at the robot. But many colleagues still think that open surgery is the best because they ask you, did you touch the tumor? They don't understand that those probes going in can also touch the tumor. There may be some challenges and deficiencies here and there when you're doing laparoscopy, but laparoscopic assisted colectomy is now gaining ground, and we can now operate both on the right side, transverse, left side, and even the lower part of the colon. We can also do total colectomies through this. When do you consider surgery? The surgeon has to be experienced. Not everybody can do this if you have not trained very well. And again, for diseases that are beyond stage 3, laparoscopy might not be a very good issue, but you can also use it to diagnose and check on the extent of the disease. It's also contraindicated in acute bowel obstruction or if there's perforation, simply because in acute bowel obstruction, the bowel is so distended, you don't have room for your instruments to play. So even if you put in gas, you don't get room to play around. Otherwise, the use of the ERAS protocol, that means we're enhancing recovery of patients with the laparoscopy and other adjuncts is what is now considered these days. So advantages of laparoscopy, we have improved visualization. I see inside the abdomen the way I'm seeing you people in this room, which I cannot do when I do open surgery. There's some corners I'll not be able to see, but a laparoscopy I can see. And of course then, because of that, I can actually walk the bowel from the DJ to the ileocecal junction very easily, flip over the omentum and check, open up spaces which I can not easily see sometimes in open surgery. And then this is through very small incisions, so there's less pain, patients recover very fast. And because we don't handle bowel a lot during laparoscopy, it means that ileus is quickly done away with, and the bowel function resumes very fast for patients, unlike when we do open surgery and we touch the bowel. Of course, there's better recovery, and then therefore the hospital stay tends to be shorter during laparoscopy. The blood loss is minimal. What are the disadvantages of laparoscopy? Of course, one of the things is it's very expensive in most of the cases because of the equipment we use. We may sometimes have inadequacy of the resection margins because you are not able to feel like when you touch with your own hand. There are many studies that have been done now to compare laparoscopy and open surgery, and you can see the oncologic outcomes we have in patients for laparoscopy and open surgery are not so far different. Ladies and gentlemen, I had a video I wanted to show you, but the timekeeper is so unfair to me after giving Ayua, because I'm a surgeon. Ayua got a lot of time, but I appreciate the little time I've been given. Thank you.
Karibu sana. Daktari, we appreciate you. Feel at home. He's the director of surgery at Kenyatta National Hospital, and we work very well with surgeons. They even have us also going to speak at their meetings, so we are nice to you. Karibu. Daktari.
Thank you very much. He's very clever. He had many excuses today. His video just didn't work. Hakuna mtu amemwonea. So thank you very much, gastroenterologists, for giving me a slot, your slot in the Kenya Association of Physicians meeting to talk about the current advances. You had given me the whole slot of colon cancer. It says here. But it's such a wide topic because there are very many new things. I thought that I'll limit myself to the issues surrounding metastatic disease, and some of which I think Dr. Ondede has actually touched on a little bit, mainly just touching on, you know, what some of the mortalities and the morbidities would be and why it's such an important disease. I've listened this morning to some of the screening procedures and, you know, some of the preventative issues. I don't think we can prevent colon cancer completely, but we definitely can pick it up early as a polyp, and basically some of those mucosal resections we talk about can be curative. By 2025, there'll definitely be an increase, an increment in the cases of colon and rectal cancers by 71 and 60%, and then of course a huge burden in our economy and in public health. So Dr. Ondede has touched on the resectability issues. I wished he touched on a little bit on what excites us oncologists on resection of metastatic lesions, especially the oligometastatic lesions in the liver, especially, and in the lung, where we are doing a lot of neoadjuvant chemotherapy to do VATS resections, and also liver resections when we give neoadjuvant chemotherapy to limited metastatic lesions in the liver and in the lung. And when we stabilize them with chemotherapy, do RO resections, we get very good outcomes and long progression-free survivals when surgeons do a good job. I think one of the limiting things for them is having intraoperative imaging to be able to tell whether they've done a good job, and also doing frozen section to be sure that they have an RO resection before they get out of theater. So when we individualize care of some of these chemotherapeutic agents, we think about the overall health of the patient. We think about their core medications. They're on antihypertensives. They're on the PPIs we are talking about this morning. We talk about their compliance, psychosocial factors, including compliance, whether they are going to come back for follow-up after we've done those metastectomies, whether they are going to come back for imaging, the follow-up on adjuvant therapies. The routes of administration of chemotherapy is very important because we have multiple oral chemotherapy agents as opposed to the IV formulations. Sometimes the costs of putting chemopots because of the infusional chemotherapies, which we call the routes of administration. When I talk about metastatic disease, you know, the chronicity of treatment means we have to spend between 100,000 Kenya shillings to put a chemotherapy pot so that we can give them repeated 5FU. Over the years, we shall keep them alive. And then, of course, the side effects profile when we choose these drugs, the biologies of these tumors, The location of the tumors, this morning you've talked about right-sided tumors vis-a-vis left-sided tumors in presentation, in the biology. Right-sided tumors probably having poorer responses to right-sided tumors, especially to EGFR, EGFR targets. And of course, the presence of RAS and BRAF mutations, and I'll talk about microsatellite instability. So colon cancer is quite a big problem in our setup, and probably the reason it even comes right down there is because at this time of the GloboCan data, scoping was not as prevalent as it is now. Probably as our data improves in our next GloboCan data, it will be a little higher, as we've seen esophagus to be in the coming GloboCan KEMRI data. So despite all these good treatment modalities, despite Dr. Ondede doing a good resection and us giving chemotherapy, nearly half the patients will have recurring colon cancer. And then, of course, some of these cancer cells are resistant to our chemotherapeutic drugs, and they resist chemotherapy by having efflux and influx modifications. They have ATP binding cassette transporters overexpression, where they get rid of the drug as we give it. And of course, we have to come up with new treatment modalities. So what is in the pipeline includes target immune boosting therapies, non-coding RNA-based therapies, what we call probiotics, natural products, oncolytic viral therapies, and I think my pointer has refused to cooperate. Is it working? It's not, eh? So it's not me. Okay. And of course, oncolytic viral therapies, biomarker-driven therapies, showing very promising reports in clinical reports. But what we have now, in metastatic colon cancer, these drugs, 5-FU remains a very, very important old drug from 1985. Then came irinotecan, the capecitabine, which is basically a 5-FU backbone, oxaliplatin. Then came the EGFR drugs like cetuximab, which is a monoclonal antibody, the VEGF inhibitors like bevacizumab. Then we got another monoclonal antibody called panitumumab, then aflibercept, regorafenib, which is an oral VEGF inhibitor, and another monoclonal antibody called ramucirumab, and of course the trilofulumab, the TAS-102, and very exciting drugs, immunotherapy, the pembros and the nivolumabs. Now these immunotherapies require for us to do MSI, MMR instability tests on tissue, and they are very good in stabilizing our metastatic patients who are heavily pretreated. But they are very heavy on the pocket. And when we tell patients that we are going to treat them until progression, sometimes that remains the difficulty. So sometimes survival have changed up to 35 months if they are able to sustain some of these drugs. So the increased number of treatment lines has been associated with actually survival benefits in metastatic colorectal cancer. So patients should actually be exposed to multiple lines, and I'll talk about first line, second line, third line, probably maintenance therapies. When you finish your second line treatment, they have stable disease, and probably drug holidays. So patients should actually be offered some of these multiple lines. And I know issues of, affordability are really very dear in our setup. In this study, they looked at a subset of over 400 patients to see how many were offered multiple lines of treatment, and there were over 400 patients who were offered first-line treatment. Some of them got a recurrence, and only a few were offered second-line treatment. I think 73% had disease recurrence and were offered second-line treatment. And then, they benefited from the second-line treatment. Only 50% were offered third-line treatment, Yet around 31% of those patients got very good outcome up to fourth line treatment. So some of the decisions we make when we're looking at first line treatment, Dr. Ondede has touched on. What is a tumor burden? Some of these patients have metastases in the liver, in the lung, in the bone. Where is the tumor located? Sometimes we look at right-sided, left-sided tumors. Sometimes they have tumor obstruction, and we have to send them to the surgeon first before we give them chemotherapy. The tumor biology as well, whether they are KRAS mutated, whether they have BRAF mutations, also helps us choose some of the drugs. The BRAF mutations sometimes will tell us about, their prognostication and the choice of drugs. Patient characteristics like age, younger patients tend to tolerate treatment better, younger patients tend to afford less. Their performance, EGOG performance status is also quite important, organ function and comorbidities, patient attitude, because patient choice is also quite important, expectations as well, because this issue of alternative treatment, where they go to eat vegetables and fruits and shun chemotherapy, also gravely affects their patient outcome. A case in point is a famous story of Steve Jobs, who chose what we call diet therapy. So when we look at all that, if we make the right choices, sometimes what we choose for second line and third line is based on toxicity profile. For example, if we chose oxaliplatin and they get significant peripheral neuropathy, we may not be able to put them on a maintenance of capcitabine, which is going to give them a hand and foot syndrome. So probably for second line, we choose an irinotecan-based drug. And then, of course, the flexibility. Not many people can be able to manage having a chemo pot and continuous infusion where they are going to come and have their chemo pot flushed and removed. And also some people are not going to manage chemotherapy agents where they need GCSF injection. So sometimes we look for the oral chemotherapy agents like regorafenib and capcitabine-based treatments. Social economic factors are heavily weighted. NHIF has been doing a very good job in supporting patients. Let's see what happens with the new social one. And of course, the quality of life being very, very important when we are talking about patients that we shall not cure. So all these therapeutic goals need to be considered. We are trying to keep our patient alive, looking at this as a chronic disease, looking at all the active agents that we shall use, but most importantly, as we try to increase the overall survival, I've talked about, sorry, I pressed that very quickly. I wonder if I can go back. I have no idea what I've done. I was going to talk about, okay. Now it's completely gone. That is not sabotage.
I think, Dr. Kiarie, your time is up. Very interesting presentation. I think it will come in the questions. So we'll have the panel stay where you are. We get the questions, or you can get the seats up there. Let's take the first question. We had the first papers that were the screening procedures. I think we shall also include them here. We have Dr. Jua, Dr. Linda Gazara, Tawambui, and the storm goes on. Will Professor Dr. Anwatch.
Let them sit down.
Go ahead.
Thank you. This is continuation from episode 1. I had the presentation on this H. pylori like we had on the first day. Now, the quality of the science was very good, but the value is reduced by 50% because they all declare that they were sponsored by a farmer. which reduces the credibility of your presentation, because you can only talk about the good things about the product and its value. Most of all, even the medical director for Gate Pharmacy, there are very few side effects, but didn't say which side effects are there. I'm sure there are not few, there are very many side effects, but there's no way you can tell us the truth. So I think we got away from this idea of being sponsored to come and talk about a drug by a pharma in an physician conference, because you know very well you're not adding much value to the science, because you're just promoting the drug.
I think somebody will answer your questions, but Dr. Joby wants to answer you. Professor Joby, go ahead.
I couldn't attempt to answer J.A. My question is thank you very much for the brilliant presentations. I didn't know how much gastro I've forgotten, and yet I eat every day. Dr. Farida and Kiare. Farida, you mentioned that in the early detected squamous cell carcinoma, you can strip the mucosa. How much does that affect or impact the outcome? And I remember Kiare saying that it can be curative. So what role does it play in the overall management of squamous cell carcinoma?
Okay. Yeah, thank you very much, Prof, for that interesting question. Yeah, so actually endoscopy has become quite advanced at diagnosing these esophageal malignancies early. And even, it's just that the time was short, but if you want to delve, you can actually really go deep. And the scopes we have today, other than showing you NBI, what I told you, it's just a press of a button and you can see the brownish coloration, which suggests possible malignancy. They also have magnification endoscopy, so you can magnify the lesion once you've detected it. And those, when you magnify the lesions, you can be able to detect the microvasculature. And based on the microvasculature, you can predict the depth of invasion of that tumor. So once you have done that, you've seen the vessels, you've determined that this lesion is unlikely to be involving the muscular layer, then you can do endoscopic mucosal dissection and provide cure for that patient without requiring further treatment. So yeah, it's quite exciting.
I think that is an excellent answer. However, screening for cancer or detection for esophageal cancer, the impact, what would you be screening for? Because not everybody has access to endoscopy in Kenya. The tail end of the people who have esophageal problems will go to the endoscopist. So you are catching a very small proportion of the population with the screening method you are talking about. In fact, the screening method you are talking about is maybe detection of those who already have the problem. So I would like you to tell us, say something more about screening that the fellow in the village will do, the physician will do, to be able to say this is probably a patient that should undergo endoscopy.
Prof, if I may usurp her time for that question. Speaking about a patient who is already diagnosed to have a squamous cell tumor, both esophageal and rectally, and staged as very early disease, those mucosal resections can be done using those methods where you use a scope and use an ultrasound. But it's very important to have the capacity to also do a frozen section in theater and ensure that you have a clear margin. But they are very useful modalities because that's all you need to do for the patient. Maybe the screen.
Yeah. Like I mentioned in the presentation, thank you, Prof. That's a very important question, and I think it's a gap we have in our population, in our, that African corridor, because in the Western world, it's not a problem for them, so they don't need to focus on that issue. Their incidences are going down. Even the Asian countries, as their socioeconomic status has improved, it's becoming less and less of a problem. So we are left with the problem, but we don't have screening guidelines. So at present, what we have is, you know, the obvious ones, you know, like the patients who have head and neck cancers, which I am not even sure if everybody is routinely sending them for endoscopic screening. So we really do need to develop guidelines for our population, especially in the high incidence areas of central Kenya and western Kenya. So we don't have guidelines at present. It's just maybe if you're doing an endoscopy, you can develop the good habit of checking using NBI, your esophagus as you come out. But it's a gap we have, and maybe the Gastro Society of Kenya can over time work on filling that gap, because it's our problem and we need to address it.
Good answer. Let's hear what Smita says about this.
Actually, we have some low-cost technology available, and I think this should be instituted. Basically, it's called a sponge cytology. Piece of sponge which has serrated edges, so it doesn't, you swallow it, and you keep moving it up and down. It's like brushings. Bring it out and subject it to cytology. If it's positive, you go ahead and do an endoscopy. It's low cost, it's underutilized in our setup. I think it's one of the things. Eric, the ball is in your court. Maybe we should work on that. Besides, of course, the endoscopies and all.
I think she's a fellow in Aga Khan Hospital, and I think you could look at what is easily available. Whether history taking alone by the physician or by the medical officer could point out those patients that are likely to have something. We had that a lot in the rectal carcinoma, rectal problems, where a good historic picking up alarm symptoms is very useful. Probably we should go the same way. Using the endoscope actually has been used by the Japanese for a long time ago, and managed to bring down their stomach and esophageal cancer quickly. Next question from the audience. I don't want to talk too much. Go ahead.
Yeah, thank you, Professor, and for the great talks we've had. I would like to make a comment on the role of the other specialty areas in support of cancer treatment. One of the things we realize, many of the patients who get radiotherapy or chemotherapy end up surviving their cancer, but end up with a lot of systemic side effects, particularly talking about cardiotoxicity. So we've tried to support this area, even come up with guidelines for support of cancer patients to prevent cardiotoxicity right from the time of diagnosis, intra-cancer treatment, and post-cancer treatment. And we even have preventive medications that may actually be started early, so that these patients don't end up eradicating or getting cure of the cancer and end up with toxicity to the heart. It's important to screen for comorbidities, the usual hypertension, diabetes, lipid disorders, and presumptive treatment actually has shown to really improve the quality of life for these patients. I know we've done this a lot with Dr. Kieri and group, so it's just to encourage. Imaging is actually very important for all patients who are going to be on radiotherapy or chemotherapy, and ECHO is readily available to help in this aspect.
And through Dr. Samia, including checking their troponin and pro-BNPs as regular blood tests, including an ECG, sometimes that monitoring, and of course introduction of some of the drugs that you give them to stabilize some of those. Some of these new drugs that I talked about tend to be quite cardiotoxic in the long term.
Thank you very much. Let's shift a little bit. Let's look at Dr. Ajua. There are many people in here who are wondering what is the current therapy for an adult patient that you make a diagnosis of Helicobacter pylori. What is the take-home message? Are you using 5 drugs, 10 drugs, 3, 2, and which ones?
So so take-home message basically, like I said, is one, only look for H. pylori in patients who deserve to be looked for H. pylori in, your dyspeptic patients. And number 2, if you do have to go ahead and treat them, we'll have a new nomenclature which I'm going to propose For patients who are treatment naive and who have a low antibiotic use history, you should start ideally with a dual therapy line where you have a high dose of amoxil and a vonoprazan or a PPI, but preferably vonoprazan because it's superior to an extent. The other option is amoxil, clarithromycin, and your vonoprazan or your PPI. That's for those who are treatment naive and who have low antibiotic use. Those who are been treated before, treatment failure, or high antibiotic use, you go directly to the next level where you can use triple therapy, your amoxil, clarithromycin, and your vonoprazan, or amoxil, levofloxacin, and vonoprazan, or quadruple therapy.
Any questions, Professor Joe? Let him ask, but then you come in.
I don't know who will answer this, but how common is Whipple's disease? Sometimes I see patients who have cognitive impairment, they have seizures, and they have some GI symptoms, diarrhea and so on and so forth. When you do the MRI brain, you see a lot of white matter disease, and you suspect this might be Whipple's. How common is Whipple's?
Initially, we used to do PAS stains, PS stains on small bowels when we were doing endoscopies. But now I just find cytology, running biopsies, and we are actually seeing more of microscopic colitis, seeing more of Crohn's, and all sorts of other things as opposed to PAS. Although we use doxycycline when we have problems like bacterial overgrowth. But Whipple's per se, I think I've had one in my lifetime. I don't know about Prof.
Saying UC, ulcerative colitis, is more common than Crohn's for the time being. We don't know whether it will increase. But you did recommend for screening for cancer of the colon or in ulcerative colitis. How often do you do that, especially in patients who are probably well maintained?
Oh, for ulcerative colitis? Okay, basically it's 8 years after the diagnosis of colitis. Please ensure a good remission, because if it's inflamed, you're not going to see anything. Moment you diagnose PSC changes the whole paradigm. The colonoscopy should be done there and then every year, because PSC increases the risk of cancer in ulcerative colitis. Crohn's, it's there. I've just recently had a patient with anorectal Crohn's. Unfortunately developed a rare mucinous adenocarcinoma in the tract of where we're dealing with the fissure. So it is there. Do your colons every 8 years and then yearly after. On the left side, probably less, especially if it's just proctitis, after 10 years.
Your question, it's your turn.
Okay, thank you to the audience. Thank you, my fellow senior gastroenterologist. I have two questions. The first one to Dr. Odede, the second one to Dr. Sajni. So, Dr. Odede, there is a lot of new developments about resecting metastasis. We call it metastectomies. And what are the survival rates, and how does it compare to chemotherapy in the metastatic disease? Because Dr. Carey told us that there's a median of 35 months. So what's your experience on that? To Sajni, most of the modalities you talked about are unaffordable, especially in the low resource setting. What's your take about occult blood testing in stool, especially in our setup, more so in the low resource setting? Thank you.
Thank you very much. Metastasis of this tumor, preferably to the liver and to the lungs, more often than not. So what happens if you have a single lesion in the liver which is less than 5 centimeters? There are those modalities we have now. You can do ablation, radiofrequency ablation. You can do embolization of some of these lesions. But once the tumors go beyond 5 centimeters, it becomes risky to use some of these adjuncts of treatment, and surgery becomes the option. If you have 3 lesions in one lobe, confined one lobe, it is easier to go surgically resect and get out. In terms of outcomes, they compare very well with what chemotherapy does, but you know that very well, once you have lesions that are going beyond 4 centimeters, 5 centimeters, chemotherapy will not be able to shrink and obliterate the lesions completely. So we need to intervene surgically or radiologically somehow. But the outcomes are very, very comparable.
Give her the mic. Yes, thank you very much, Dr. Ndede.
Thank you for the question. So like we said, I use the Kenyan guidelines. So they actually say that first history, stratify the patients into high risk and average risk. For the average risk patients, yes, start with a stool FOBT. That is more available, more affordable to all patients. And then we go, only for those that are positive, then we go to the colonoscopy. Not all patients require colonoscopy at the word go. And like Prof. Lule said, history exam most important.
So what she's saying, the mainstay of screening is going to be stool for occult blood, whichever method you use. You had one last question, and I think I'll have to close. I'm very sorry, but let's hear your question.
Prof, can I add something very quickly about the metastectomies? So very quickly, patient selection should be very clear at the beginning after staging is done. It's usually for limited metastatic disease, usually the liver, the lung, and sometimes bone. So we give neoadjuvant chemotherapy to sort of sterilize, and then we have an MDT discussion on whether we'll ablate, radiate, and resect, and then give more chemotherapy afterwards. And we always aim for RO resection if we're going to resect. Thank you.
Thanks a lot for those wonderful, very comprehensive presentations. My name is Dr. Gitari from Embu. My question goes to Dr. Ajua. It was a nice presentation, Ajua. One of the take-home messages I've got from your talk is that you look for, you do H. pylori testing only on patients who have got suggestive signs and symptoms, right from the history exam and all that. And then if the H. pylori is 2 antigen is positive, go ahead and treat. But there are these patients who are quite common, who check into office with, they are symptomatic, they check into office with H. pylori stool antigen test that is positive. Probably maybe her self-request in one of the labs as a patient was going to get some Panadols for a headache. What do you do with this asymptomatic patient who tests positive for H. pylori on relevant, on H. pylori 2 antigen test? Thank you.
Very nice question, very pertinent and controversial. Carry on.
Yeah, so in that case, yeah, unfortunately, that's the state of events. Apart from self-request, you also have the commercial part of H. pylori, which is now becoming a big problem. I've seen guys who had gunshot wounds to the head, and an H. pylori test was done in the ward. You wonder why. Anyway, in your answer to your question, simply, it becomes medical legal. H. pylori is, at the end of the day, carcinogen 1. There's a risk of gastric carcinoma, as much as it is low in our setup. If you do find a patient who is H. pylori positive, regardless of the symptomatology, you're stuck and you have to treat. That's the final answer.
The golden rule is test and treat, because if 10, 15 years later, the patient comes up with the CS stomach, you'll be liable for imprisonment. Linda Gathara, we have one question at least. We talked about that, and you talked about hernia and whatever. Tell us, how often is hiatal hernia associated with GERD? Every time I see people on GERD, they talk of hiatal hernia. Does GERD, is it equal to hiatal hernia?
Oh, okay. Okay, there's been a lot of debate definitely about GERD and hiatal hernia, but I did a study on the association of BMI and GERD in patients undergoing endoscopy at our hospital. And one of the conclusions is that Hiatal hernia contributes to GERD. And for many years, there's been that debate, but now it's now understood that there's both the mechanical and there's the structural. So when you have a hiatal hernia, of course, the risk for GERD is higher.
Thank you very much. I think we keep it at that. Let's all clap for them. They've done a wonderful job. Well done. And then we'll hand up. I think you have to stand. Somebody will take a photograph if he's available. Do I qualify to go into that? Even Murunga and Farid. This has been the largest panel we've had in this conference. Gastro is high. Where is the photographer?
Thank you.
So thank you very much. First of all, I mean, it's an amazing thing that Gastro Society have just begun, and you can see how powerful the team is. And then they're even following gender balance. Before it used to be men, now the ladies are coming out strong, and it's quite fitting considering it's International Women's Day. So for all the ladies there in the room, happy International Women's Day. They recently had elections, and Dr. Eric Murunga was made the chair of Gastro Society, and he assures me we are going to be seeing them in quite a strong way. So thank you so much. They have played such a big role in this conference. Now, I know we're doing very bad on time, and I promised that we would improve today, but you see, our conference would not be complete if we don't hear from our patron. He is going to tell us about the evolving nature of evidence-based medicine, the challenges. If I were to actually give his bio, I'd be here all day, but suffice to say that when he's not the patron, he's also a consultant pulmonologist based at the Nairobi Hospital, and he's the one who's been keeping our conference very engaging. He's attended every session, and we thank you for that. So karibu daktari. And also, he's the only one I can't switch off slides, so Prof, please keep time.
Thank you very much. This way. This one. Thank you. It looks like the Gastro people have swallowed us literally in this conference. So some of us pulmonologists are now few. This is not a commercial break, so you can sit back and relax. It's not a sound. This is not a presentation. This is a talking point. I have nothing to declare. I didn't have the chance of being sponsored by a drug firm. That's kind of the outline of what we're trying to talk about, roughly. Now, evidence-based medicine. The term evidence-based medicine was actually introduced by the Canadian team in 1991. Why? They were putting emphasis on clinical practice from a type of evidence rather than relying on decision-making by a few people with unsystematic clinical experience. In particularly, avoiding marketing efforts of pharmaceutical companies using the guideline, like most of you who are presenting today. You're giving us evidence from pharmaceutical companies, which actually is no evidence. and medical decisions were made often after a senior cardiologist like Ogola. That makes a lot of sense. This is good guidelines. And some of the endocrinologists will remember K.M. Albati, who had the so-called K.M. regime for management of diabetic ketoacidosis. That was acceptable. Bradham Hill was actually the earliest people in history to introduce kind of meta-analysis of statistics in lung cancer. They were not doctors, but they were statisticians. They organized a research on people who smoke and lung cancer, and statistically evidence showed that clearly that there was statistical association between lung cancer and smoking. Then the pathologists took it away from there. That was the beginning of evidence-based medicine. Even the father of clinical medicine, Dr. Osler, who was John Hopkins, advocated a lot of aspects of evidence-based medicine in those early days. So, what is evidence-based medicine? David Sackett in 1934 put kind of a seal on the definition of evidence-based medicine in his article, which was entitled, What is it and what isn't, it isn't, in 1996 in BMJ. This article has been quoted over and over again on those people who are talking about evidence-based medicine. Basically, it defined as the concession, explicit, and judicial use of current best evidence in decision-making about the care of their patient. So basically, defining evidence-based medicine as the science of integrating the best available evidence from clinical research with unique patient's experience values and a physician experience as well. Or has it temporarily stopped? Okay. Now, why the sudden interest in evidence-based medicine? It's been known that with increasing a lot of knowledge in the medical world, there's a need for valid information about diagnostic therapy and prevention of most diseases, particularly in the area where the patients are now aware. And most patients refer to Global Organization of Oriented Group of Language of the Earth, which is GOGO. And I'm sure most of you didn't know that GOGO stands. This is what GOGO stands for. How many of you knew here? So this is why I said this old man is very IT savvy. Also, the knowledge of doctors' practice must increase. Now, if you just sit down and practice medicine for 20 years, you become, we call them ritualists, and those are witch doctors. And a lot of doctors are like witch doctors because they just practice what they've been doing for the last 30 years without updating themselves, okay? And it is important because every day you need some evidence. Most books you're reading are out of date. The journals are now disorganized, and most physicians have very little time to acquire information. In fact, most doctors are drowning information, but they have very little knowledge of what to do. In fact, poor time clinician is suffering. It is, this one doesn't go back. Okay. If you are to be up to date, you're supposed to spend 1 hour per week, Professor Gola, reading journals. That's about 19 articles per day for 365 days in a year. Now, even if that's all you're doing, you're paid for, you're not likely to do. So it became impossible to read journal to keep up to date. So a clever man called Archibald Cochrane, a British scientist, decided to have a Cochrane collaboration, which basically a reliable summary of all studies we have done these studies, and okay, they talk about many studies and quoting, but you have to define what studies you're doing and what level of evidence they give you. You can do a lot of studies in Eldoret backyard, but what type? Is this doing reviews, clinical, randomized case trial, or just expert? Editorial, you know all about these labels of evidence from editorial and experts, case series, case reports, case control studies, court study, I don't need to remind you. But this is the most important thing in evidence medicine. That is random clinical trial, which has been used for years as the basis of clinical trials associated with the meta-analysis. Now, outcome trials, which Professor Ogola was talking about yesterday, is the end result of medical care, okay? The effect of health care process on the health and well-being of patients and the impacts on the patient population. So you want not how many of them are going to die, but how many are going to live and what type of quality of life. That's the outcome of the research. Because as you know, Professor Gola, that the only one risk of death, that is being born alive. That is the highest to die. The rest of the things that happen when you are born alive are just interfering with the quality of life. They have nothing to do with, you're going to die anyway, one day or another. Okay. So these are some of the benefits of evidence-based medicine that have been talked about over the years. Outcome is the only thing that matters in life. Either you succeed or you fail. But opportunity to change for the better from failure to success was actually brought about by ABM. But unfortunately, there are a lot of challenges in ABM. Some people think it's useless if there's no evidence, but if you use it properly, your evidence, care for the patient, and you don't ignore the judgment of expertise, which still accounts a lot. And evidence-based medicine, not just numbers and statistics, is the numbers not in a vacuum. The evidence must be individualized to each patient, okay? These are some of the challenges of medicine. Not all evidence is equivalent. We said there's a hierarchy of study design, but the important thing that external evidence can inform you, but it can never replace individual clinical expertise. So Professor Gola, your expertise still remains. Forget all this other evidence I'm talking about. Always, you can ignore them if you've got good experience like you have. The values always influences decision. Now, COVID-19 was a turning point in EBM. It completely altered the inherent limitation of clinical trial landscape. This shook the confidence of most doctors towards practice of EABM. There's discrepancy between availability and demand of evidence, because there's so much demand for evidence to treat COVID patients, but there's no scientific evidence. And journals started being in a hurry, started publishing incomplete and at times misleading scientific articles. There's a lot of non-documentary evidence to treat COVID-19 patients. Evidence was hypodermic and volatile, and sometimes with political influence. As you remember, President Trump used hydrochloroquine and pronounced it very effective in COVID. That's political influence and was taken away by some scientists. However, COVID-19 spurred some positive changes. A shift towards patient-centric intuition evidence generation system, combining clinical experience and clinical trial. So you don't just talk of evidence as, yes, Doc, Rosie, you gotta give me some water. Thank you. President Trump allegedly took HKSQ and said it was very useful in COVID. But those are political influence. There's some limitation of EBM. you may relegate clinical judgment because of basing yourself on on the EBM. There's a problem that over the years, particularly the cardiologists, have focused on drugs and devices, and their clinical trials in the management of various cardiological situations. There's a lot of clinical decisions which can be based on evidence that can be impaired. There's also some error that may lead to major abuses and end up in inappropriate guidelines and dogmas. Despite its success, there's never been an agreed definition of evidence-based medicine. Yet evidence-based leaves great evidence related to healthcare and other fields of health policy report. It can be subject to motives of research, commissioners, other commercial or political interests, and may actually lead to a lot of bias and distorted view that matters in medicine and health. So there's no evidence in evidence-based medicine because it excludes many types of treatment. Intentions to treat do not reflect post-RCT changes. It excludes severe cases. RCT is not available for etiology, diagnosis, and prognosis. So clinical decisions are often restricted to the best available evidence. So RCT may not be relevant for all treatment situations. And research tend to focus on specific population, yet we know that individuals can vary substantially in population norms. There are several under-researched populations, race, age, or comorbid condition, and evidence-based, evidence from RCT may not generalize this population in race, age, and comorbid, which we also talked about yesterday with Professor Gola. So EBA applies to groups of people, but you must have the personal experience of the clinician, because sometimes EBM ignores observational and theory, history and philosophy of science, and it gets sometimes the evidence method used to collect it. It does not meet the efficacy always test, and reduces clinician-patient autonomy. Those are some of the challenges of EBM. Randomized clinical trials have been the gold standard for evidence generation. But conducting RCT is not always feasible due to challenges in generating the evidence in a timely manner and the costs involved and ethical barriers to conduct this trial. By the time some of these trials are completed, they already become outdated and in some cases irrelevant to the current context. So using them may not necessarily give you the right evidence. Traditional design must adapt to contemporary rapid advances in genomics, immunology, and precision medicine. In fact, RCTs are unrepresentative of all trial subjects. A well-designed clinical trial we know have inclusion as exclusion, age limits, comorbidity, concomitant use of drugs, and a range of clinical and biochemical criteria. This often leads that only a minority of those with condition under study are recruited, which makes it difficult for you to generalize it in the population. So we need a paradigm shift in RCT. Future clinical trial, I don't know what that is. That's unusual, but it's okay. Future clinical trials so will require fundamental transformation to give you evidence-based medicine. We must design them, conduct them, monitor, adapt, and be reported in different ways. Avoid bias due to pharma funding and fair presentation of RCT in journals. It's also been found that doctors who are contracted by pharma to do research often are also compromised, and they only produce the correct results. And the journals have also been found to be compromised. They only print the positive aspects of certain drugs on trial. So we need to have a shift for more patient-centric to the evidence generation system and patient participatory medicine. embracing technology by all stakeholders, the new generation of physicians, pharma, and other most authority doing the research must change. Advances in wearable technology, data science, machine will transform evidence-based medicine in future. In fact, advancement in exponential gains in genomics, immunology, all this mix and mix will actually improve the data. And big data science, particularly OMT. What does OMT stand for? Anybody knows? Incredible. Net of medical things. You don't know. You are always a bit poor in technology. In other things called IoT, Internet of Things, but in medicine, they put in the M1. These are the devices using the internet that you put on patients to collect data. It's called Internet of Things. And this is itself can do a lot of research. The dawn of CRISPR. Now, does anybody know what CRSPR stands for? It is the in thing in technology. Okay, I'll tell you. It means cluster regularly interpace short palindromic repeats. It's a technology that uses selective modified DNA of living organism. It was adapted in the laboratory from naturally occurring genome editing system found in bacteria. You all look amazed. I'm saying like we should not be teaching you this. You should be teaching me. Now, that's time for you. So, evidence medicine may minimize patient care, cause treatment, and all those lifelong treatment. But the future is different. It was launched on a powerful rhetoric rather than rational discourse, but it needs to be independent in the selection of topics and mode of research, which must avoid pharmaceuticals, pharma and politician. And I said politician, I mean pharma used in doing research and presenting prism. It's like politicians going for election and they are the returning officers, they are the one who count in the votes of their results. Obviously the result will always be positive. We must be willing to integrate challenge aspect of all medicine in healthcare rather than just drug and device. And we must avoid commercial, ideological, or political influence. There will have to be a change in EBM if we are to have a meaningful wider context. So conclusion, medicine is not an exact science, but a science of probability. The challenge of physicians is to provide up-to-date medical care. The ultimate goal for clinicians should be to help patients live long, functional, satisfying, pain, symptom-free, live long and not die. By adopting the principle of evidence-based medicine, it may be possible to maximize the benefit of scientific research. Parting short, there is no evidence and unlikely ever to be that evidence based medicine provides better medical care in total than whatever we would like to call what went before it. A few questions then answered. How does EBM operation work? Who determines what will be disseminated? Who chooses the decision makers? Who are the qualifications and the credentials? And above all, who determines the topics are chosen to receive meta-analysis appraisal? Those are questions for you. There end the gospel according to Dr. Lodge.
I don't know if I'm allowed to say it was the patron's presentation, no questions allowed. But if you're brave enough, I think Prof. Ogolla is the only one brave enough to ask questions or make comments. Karibu Daktari.
Yeah, thanks, Joe. Maybe just a few comments, banter aside. Obviously, you said that we have to have some evidence for the practice we do. I mean, there has to be a reason why I don't use corticosteroids to treat heart failure, for example, but I use them to treat asthma. I think the confusion comes when evidence-based medicine is used synonymously with randomized clinical trials. Those are two completely different things. As you rightly said, evidence-based medicine is the use of the highest available evidence. there are certain pieces of the evidence that cannot be generated by randomized clinical trials. We didn't randomize people to smoking versus not smoking to determine whether smoking is a risk factor for malignancies or cardiovascular disease. And like you rightly said, randomized clinical trials or statistics in general look at populations of people. We deal with an individual. Statistics was never meant to be a substitute for a brain. So we still have to think. So the challenge I think you've posed to all of us, which is the right challenge, is the critical appraisal of the evidence of the person you are dealing with, whether it is a clinical situation, a public health decision, and see how the available evidence applies to that. And of course, at any particular time, there'll be an evidence gap, and that's why we continue to do research. Just talking about clinical trials per se, there are obviously inherent weaknesses about clinical trials as currently designed. One of them is, of course, the populations that are included. Two is the costs that are involved, which make them predominantly done by industry, and therefore potential bias. And an additional thing which is actually important, which is related to the fact that they are done by industry, is inclusion of all populations in the world. I mean, there's data that I've presented very many times to you guys have listened to, and we have a paper actually undergoing review now, looking at the population, the inclusion of all populations in the clinical trials in heart failure, for example. And the black population is less than 5%. Now, that is not an inherent weakness of a randomized clinical trial, but a weakness of the environment in which we are doing randomized clinical trials. I think I've spoken enough.
Thank you. I knew you were my brilliant student, but I didn't know you were this brilliant. Thank you very much. You said nothing.
Thank you so much. This is vintage Joe at his best, really. You're always good, innovative, and doing things that is really good challenge. And I don't think you're really saying that we should not use EBM, because then we'd also be practicing witchcraft. But I think we are saying there's a role for it. Now, a question for you, past, present, and future. How has holistic care changed? Because we do not treat the disease the person has, but the person who has the disease. And sometimes we treat the results and we treat the research findings as opposed to the individual themselves. And I think if you can be able to just bring that up to us, again, using your gray wisdom that you've had over the years, to just help us to see the role of holistic care for that individual.
You know, what you're trying to say that I think EBM was over embraced, and everything it is a golden answer to almost of our quality medical practice. But we realize that it is useful, but not as useful as thought. It left many questions unanswered. And as I say, most important thing that it ignored for a long time is your experience in clinical practice. So now it embraces that. And particularly during the COVID, it was so clear that there was nobody going to do clinical trial to get evidence, to treat evidence. So patient care experience and whatever other research you may have, all combined to give you the evidence to practice better medicine. That is called evidence-based practice, as opposed to evidence-based medicine, which is mainly trial-based. So, for example, we're going to use AI. For example, during COVID, it was AI that discovered that there was smell loss in cases of COVID, not the doctors. And they used the Blue Boy computer design. How many of you know the Blue Boy computer? It was designed by the Canadian. The Blue Boy computer can read 86 languages in the world, both lay journals and medical journals. So you give him a question
what is COVID being talked about in journals in the world? In 5 minutes, it give you a result from 86 countries. That's how they discovered that most people with COVID were having. I'm very disappointed. You guys are not really IT up to date. And medicine is now IT. Now, tomorrow we're going to talk about artificial intelligence. I'd like to see how many of you will come in. Then I'll be part of the discussion.
Okay, big round of applause for our patron. He's supported us at every conference and always manages to give us an extra pearl of wisdom. It's amazing how he manages to keep up in all his years of experience, and we're always happy to learn from you. Thank you, patron. Now, as you can see, we're running a little late, and we're not going to have the next presentation. What I'm going to do, because I can already see the dull faces, is I'm going to release you for a short tea break up to 11:30, because our next talk will be talking about the collaboration between the Royal College of Physicians, Edinburgh, and the EXACOP. And it's an online, we're going to have the initial presenter, Dr. Wamithi, and also Mike McKenzie. So I urge you all to be in by 11:30 so that we can actually kick off. And then thereafter, I'll give my talk on novel molecular target for management of diabetes. And then we'll have the talk by Dr. Martin Wanyoike. And then thereafter, break for lunch at 1:15 latest, up to 2:15. And in the afternoon is when we will then have the session between the nephrology and rheumatology, and thereafter neurology and the research, so that we hope to finish by 4:15 in time for team building. So I urge you all, as always, please remember to fill in the feedback forms. Remember, we are only here, we are supported very well by farmers, so as you go and take your tea downstairs in the tent, please pass through the farmer booths, but be here by 11:25 so that we can start at 11:30. For the feedback forms, just place them at the registration desk. Don't forget to write your KMPDC number. The CPD points are only going to be given at 4 p.m. today. So you have to attend the rest of the day. Thank you very much for your patience, and have a good tea break.
Hi, Mike. And Ninette, can you hear me? Dr. Mackenzie? Okay, can you hear me? Hi, Mike. Can you hear me?
Yeah, I can hear you.
Oh, great. Okay, thanks. I will let you know once people have come from tea break, and then we can just start.
Sure, okay.
Great.
Fine, sir.
Okay.
Good luck.
All right, thanks.
Newcomers, good morning. Good morning. If you're outside of the hall, can you please settle in? Remember, this is an online session. We really apologize, Mike, for keeping you waiting. I promise on other days we keep time. So this is going to be a combined presentation from the Royal College of Physicians, Edinburgh, by Dr. Mike Mackenzie, and from EXACOP, our program manager is Dr. Nancy Wamithi, and the strategic lead. I'll give her the chance. I don't want to preempt her talk, but it's amazing, and I was really hoping for a full house because it involves all of us. So I'm encouraging those who are outside of the room to please come in. In the interest of time, we're going to allow for her to present, and then thereafter Mike. And we'll have a Q&A session so that we don't keep Mike waiting. And Mike, we promise we're going to keep time. Apologies for keeping you waiting. Welcome, Dr. Wamithi.
Good morning, all. My name is Nancy. I'm the program manager for the academic program, Internal Medicine Fellowship Program. So I'll take you through what our partnership is with the Royal College of Physicians of Edinburgh and KAP. That is Dr. Mike Mackenzie. He's a Scot physician who we worked with when we co-applied for this grant. He's logged in because then he'll speak about what the UK will do for the partnership. Also in the meeting is Ms. Ninette Premdas, who's the international manager for RCPE and who's in charge of the MTI, the MTI initiative, and also works with a lot of South-to-South partnerships in Africa. Okay, so happy International Women's Day. Unfortunately, I had told Rosie to make the room purple because those are official colors for this day. I think I've only seen one lady wearing purple, but I want to celebrate the women today. As you saw even yesterday, as we brought in a new executive, we saw that most of the executive committee members are women. So, why are the men so dull? Can you clap for the women, please? Thank you, thank you, thank you, thank you. So, the grant is called the Global Health Workforce Program grant, which is funded by the UK government through the Department of Health and Social Care. And then THET is the fund managers, okay? So we actually launched this partnership like 2 weeks ago on the 19th of February. You can see Prof. Joe is there, Prof. Some and Dr. Barasa. And together with the UK government and WHO, so we were able to launch that in Nairobi to be able to start this project. So what is the rationale and the need for strengthening the internal medicine training in Kenya? We're not leaving anyone out. Even though we are a fellowship program, we are also inculcating MED trainers. So the whole purpose of this grant is to decentralize quality training of medical specialists, particularly physicians, using a curriculum that emphasizes on clinical competencies so that we're able to, improve patient outcomes. So whenever I'm thinking strategically about what to do with this program, this is usually in my office, and I look at it because I'm the national manager, and this is how I actually plan for the program. So we're there to strengthen formal trainee assessments of any doctor in training, okay? And there are two types of assessments. It's formative and summative assessments in teaching hospitals. So right now we have 7 training sites, as I told you yesterday. And what we'd like to do is to ensure that each region of Kenya, and we divided into 5 main regions. So there's Central region that includes Nairobi, Nyeri, Kiambu. Then there's the western side of Kenya, which includes Kisumu, Kisii, Kakamega counties. This is the North-East region that includes Uasin Gishu, Baringo, Laikipia. And then there's East region, which will include Machakos, Makueni, Kitui, and then there's Coast Region, which will include Mombasa. We already have a training site in Mombasa in Coast General. So we would like to build capacity of the physicians who are in those different regions. So we currently are working on an online module that will be available to 100 physicians, ex-ACOP fellows, unfortunately, so you'll have to join to become a fellow of the college. For 100 physicians, we already have 25 clinical supervisors who are training our fellows. So we'd like to also target physicians who are training in universities, so Prof. Joy will take you through what we plan to do on that. And then we're going to have a postgraduate examination workshop. It's a 2-day workshop that will be held here in Eldoret. So we'll bring our visitors to Eldoret, okay, to have that examination workshop, because we'd like to build capacity for you to be able to write exams and also conduct clinical examinations. So these are the different routes. We'd like you to be a certified examiner, all right, both for the fellowship exam, so that you can also be invited to be external examiners within the EXA region. So obviously there's direct appointment for those who've been examining for decades. So we'll just require you to, do the online module and then to examine. You'll be invited as an examiner in any of our Part 1 or Part 2 exams. Then for our junior to mid-career physicians, the ones who've graduated in the past 5 to 10 years, we would like you to be examiners via the shadow route. So you'll do the it's like a 6-month online module course. Then we do have mock OSCEs that we set up in all our training sites in May. Then you'll attend the 2-day examination workshop that will be in Eldoret in August. Then you'll be a shadow examiner. Every station, we have 8 stations in our exam. So you'll be the 3rd examiner in the 8 stations in our Part 1 exam that will be done in August in Eldoret. Then they've also, because Aga Khan University is an MRCP center where the Royal College of Physicians have allowed us to have some shadow examiners in that PC's exam that will be there in October or November of this year. So our online module, I'll take you through what our online module is about. So it will cover both summative assessments, how to write MCQ, SAQs, and clinical exams. And it take you also on how to supervise any doctor who you're supervising, whether it's an intern, an MO, a CO, a nurse. We're not leaving out any cadres on how to do workplace-based continuous assessments to provide feedback on how they take care of acute patients, when a patient deteriorates, bedside teaching in your MOPCs as you supervise them. So we'll be able to teach you the principles and the methodology of how to be able to assess anyone who you're training, okay? Then our summative assessments, this is to do the exams. So we have 8 units in our module. So we'll go through the theory of examinations and the conduct of examinations on how to invigilate, about cheating, changing of marks by examiners. Then there's the principles of writing a good MCQ exam and SAQ exam. And that is both for Part 1 and Part 2 because the principles behind the 2 exams are different. And that's why even during our 2-day workshop, it will be very practical, hands-on on how to write MCQs and SAQs. Then there'll be principles of moderating a written exam. Then there's a theory of clinical examinations. We are going to do videos and demonstrate good clinical techniques of how to examine patients during an exam, whether it's you're examining undergrads or postgraduates, but our emphasis is on postgraduate exams. So general exams, CNS, all the systemic examinations. Then we go through the communication stations. I think this is important on how to deal with angry patients, difficult patients, how to give feedback, right? Then we'll go through the rules and regulations of clinical exams, how to create a patient database, how to recruit actors, okay, for your long cases and for your OSCEs, how to calibrate patients and how to set up the examination stations. So all this will be taken through the online module. Just go to the next slide. It's not. So then on formative assessments, we had your feedback, Profoyo, regarding our research project. We do insist on our own trainees to do a research project. So we'll take you through on our formative assessments, acute care assessment, case-based discussions. Mini clinical examination is about bedside teaching. Multi-source feedback is about different departments giving feedback on how your doctor in training is, whether it's a lab, the nurses, any auxiliary services. And then there are supervisory reports. We expect our faculty to give reports on their trainees and on how they're doing. And then we said what we'll include in our module is how to supervise a research project. So we'll put those principles there. Then now this presentation is Dr. Mackenzie. I'll prompt you in, and then you can take us through your presentation on the UK side. I'll just, hi Mike, can you hear me?
Yes, hello.
Hi, yeah, so now you can start your presentation. I'll just, you can prompt me and I'll move the slides for you. Yes, we can hear you.
So I was really heartened to really meet Nancy online.
Okay, thank you. That was on our part. I'll just invite Prof. Joy.
Yeah. Thank you very much. Now, Nancy has actually said everything. And as we know, I think one of the things we realized is that formative assessment is not easy. We do CATs, but CATs are serial summative assessments. It's an exam, an exam, an exam. So what we really want to emphasize is the day-to-day assessment. So if I'm with Rosalind as my trainee, I should be able to assess her on a daily basis, on the ward rounds, and so on and so forth. So we have a chance for 100 people to train. We, like Nancy has said, we have the current training sites will take about 30. Then we are going to write to the chairs of departments of medicine. We have about 10 medical schools, so that's about 40. We are going to write to the chairs of the departments of medicine in all these medical schools to give us 4 people. That comes to about 70. And then the remaining 30, we are going to locate to potential training sites. We have the KDF who are already actually accredited, but they didn't train this year for one reason or another. So, and we had Kisi, which we visited last time. They were not accredited. They were not inspected. So any hospital that has a potential to train and wishes to train, we shall locate those 30 spaces so that we have 100. And see, the point is, it's not just the EXACOP trainees, it's the physician, how the physician assesses the patient, the trainees. At the end of the day, it's the quality of care of the patient that will improve, and we want that to be as holistic as it can get. And one of the things we would like, and that's the ethos really of EXACOP, is we have a broad base so that I can train in Kisi, I can train in Kwale, I can train in Kitale, I can train in Kakamega. I've just used Ks, but they could be M's and A's and C's, wherever the hospitals are. So we hope that, and I think Nancy has done a brilliant job. I must congratulate Nancy. She's done a brilliant job. So we hope that as we move on subsequently, 5, 10, 15, 20 years, some of us may not be there, but Nancy will still be there. She's probably where I am now in 30 years from now. But the point is, you young guys, we need to train you. The other thing I wanted to mention is next year, which is it's our turn, the FCP1, which is done at the end of year 2, the clinicals are done in country. Zambia does, Malawi does, Kenya does, and so on. But FCP2 exams, which is the exit exam, is regional. All the trainees go to the regional country. We started with Malawi, then we were in Zimbabwe, we're in Uganda this year. So in 2025, it will be in Kenya. So we'll have about 30 Part 2 candidates coming from all over the region to be examined in Kenya. And we need your support as consultants. We need your support as examiners. That's why we are developing this training capacity. And like Professor Yo said, we will use this training to also get the research supervision. We shall get it in there. Thank you very much. We ask for your support, and we hope that Professor Gola will retire happy, because he is going to give us 4 people from the University of Nairobi, so he can stop examining. Usually they're very little when they examine.
I wanted to suggest, because Mike has been on the call almost an hour, that we just have the Q&A now regarding this, and then we can proceed with the rest of our program. So if you have any questions regarding this, if you're interested, I'm sure you can look for Dr. Wamiti after this, but any questions you have for Professor Joey, Mike, and for Dr. Wamiti, now would be the time. If there's anything that you need clarification on.
Yeah, just a few quick comments. First one is thank you to the whole team, your leadership, Nancy and all that, for doing this, and especially for looking at it broadly as postgraduate training in the region rather than just EXACOP. So I think that's extremely important. Second one is related to that, is that we have several medical schools, but you know, the size of the student population, both undergraduate and postgraduate, varies. University of Nairobi, for example, I think our total MED class is about 100 now. For undergraduate class, each class is like 300. So I appreciate your attempt to be democratic, but I would suggest that probably you look at the burden of students, the faculty that you would whatever invite from each of this. And I would also want to say that, as Mike said, this is a two-way thing, is an interaction. And clearly there is something we can learn from people who dedicate themselves to studying medical education. But there are also important contextual factors that make this depend on the environment, and that, if you like, local knowledge and experience, like, Dr. Luwat said when he was talking about evidence-based medical education, will be incorporated in these trainings, because as much as many things are different, practicing medicine in Rochester is different from Edinburgh, it's different from Eldoret, it's different from Munich, and all that. They are local contextual factors. Thank you.
Yeah, that's a valid point. The distribution will sit as the powerful KP team that has come in and EXACOP and see how best to. That's a valid point, actually. Yes. And one thing you mentioned is the medical education. We've had some discussions, and one of the things we intend to do is the bidirectional learning. There are some medical education courses that, as we move on, this is just the beginning. As we move on, we may be able to pick up and have our trainees. A lot of them are online, but there may be some face-to-face medical education chances. Yeah.
Mine is really to thank Professor Joy, Dr. Omiti, and team for thinking of doing this. One of the things I really grope with as a lecturer is whether I'm doing the right thing, because there's nowhere where we are taught to teach, there's nowhere where we are taught to examine, but somehow we are supposed to pick it along the way. And I really wish this initiative can, with time, be something regular that allows, especially the online bit, that allows people to, even as they are engaged by the universities, to go through some of these modules at the beginning. I think it would make a big difference. I know our students, and even me as a student, I blamed my lecturers. Now that I'm on the other end, I realize just how difficult it is to do a job that you were never trained for. So thank you.
Asante sana. I think we're done. Michael, you want to say something finally?
Yeah, no, thank you. Really, I would also say, I'm really impressed by the enthusiasm and the drive we have to try and meet the challenges. And I would just really say, I think this is not just EXACOP or MRCP or anything like that. There are many different institutions. Medical education happens all over the world, and of course it has to be completely contextual. You need to be familiar and listen to someone who lives and works in a particular area. So I know that, Prof. Joy, you know that it's much College of Physicians Edinburgh. This is an international institution, and I really want to support where we can this kind of important work, and have a great rest of the conference.
Thank you very much. And is it May or June? There are 5, in line with these, in May or June, there are 5 of us, 5 Kenyans who will be going to Edinburgh, just to get some of the not really the basics, just to observe how things are done, and the 5 know themselves. Thank you very much. I'm not one of them.
I'm privy to that knowledge, but I shall plead the 5th. Thank you, Mike. We really appreciate taking your time. Have a good day.
Thank you very much for that session. We'll now move on to another session where we are going to have a talk by Dr. Rosie Ngugi. So Dr. Rosie is a consultant endocrinologist. She's also the vice chair of KDSG, as well as the assistant secretary for KAP National. So she'll be giving us a talk on a novel target in the management of type 2 diabetes. So welcome, Dr. Rosie.
Thank you, Daisy, for that kind introduction. Just one correction, former. We resigned yesterday, and we are very happy for the new team that has come. Now, because of, on the interest of time, I think I need the slide mover. Who has it? Dr. Wamithia talked about International Women's Day. I promise we're going to have purple at the gala dinner. Just a polite reminder, sorry, I know I'm organized and I'm supposed to be presenting, but just one quick one about the gala dinner. It's going to be at Lyons Primary School, which is just 5 minutes away, but we're going to provide transport. There'll be buses just downstairs outside Eka Hotel from 6:30 p.m. ferrying you across. You're not going to have to walk. Great, so now let me switch and change gears if I can have my presentation. The concept of, I know we talk a lot about diabetes, and in our field we've been very blessed that we've had quite a number of drugs coming up. Some we are generous enough to share with your cardiologists, nephrologists, but one of the things we keep trying to figure out is how we're going to manage diabetes better, because we still are associated with so many cases of morbidity and mortality, and we're trying to figure out, is there a way, one, we can either prevent this diabetes, reverse it, or if at all, manage it better. So we're going to talk about a novel molecular target in the management of diabetes. Now, slides are not moving. My slides are not moving. At time, you can't rig me out of this game when I've planned the conference. They're shy. Right, so the concept that I'm going to introduce you to, it's quite deep. We're going to talk about more of molecular stuff. I'm going to take you back into the science, so bear with me. I'll try and make sure I don't bore you too much. Now, what are the challenges we are facing in type 2 diabetes management? There's a beta cell dysfunction that we all know about, and the problem with this is it's contributing to beta cell destruction, and as a result we progress even faster to using insulin in type 2 diabetes and insulin resistance. So what do we know about the pathophysiology? There are various factors, and it's because of this that you can't quite predict everything about a patient. But what essentially happens when combined with genetics, you have beta cell overstimulation. This lies the cracks, the hyperinsulinemia, which further contributes to not only obesity, which worsens the insulin resistance, but this is also what's contributing to a beta cell exhaustion. So you're finding quite a number of the type 2 diabetics, and I'm glad Dr. Wairagu had talked about the new classification of diabetes, because we're having severe insulin resistant or depletion. So how about if we can preserve this beta cell? Now, what are we saying about beta cell dysfunction? It results from inadequate glucose sensing to stimulate the insulin secretion. Therefore, you have elevated blood glucose levels. What is causing it? Persistent inflammation, which you see in your type 2 diabetes patients, obesity, and insulin resistance. Another issue is your insulin resistance. We keep talking about this, and one of the things we've been accused of is, as diabetologists, we talk about it assuming everyone understands it. What is it? It's characterized by a diminished response to insulin stimulation, resulting in failure of these target tissues to adequately dispose of this blood glucose. So what's happening? It's inhibiting lipolysis, it's stimulating glycogen synthesis, and inhibiting your hepatic glucose output. Now, what we normally focus on is, we understand someone has insulin resistance when they have obesity. So we know that primarily at the end of the day, by the time you're presenting type 2 diabetes, the problem is at the level of the liver, the skeletal muscle, the tissues, but also the pancreas. But what lies behind this? It is mitochondrial dysfunction. And what is this mitochondrial dysfunction causing? Increased reactive oxygen species, impaired glucose oxidation, impaired fatty acid oxidation, and metabolic inflexibility. So what is this? At the end of the day, we know it's mitochondrial dysfunction that's contributing to a reduced beta cell mass, insulin production, and it also stimulates and reduces your secretion coupling. Behind that, you realize that it's because of mitochondrial DNA mutations and dysmetabolism. So my primary focus is on the mitochondria. So let me take you a little bit back to the science behind this. So we know the mitochondria are important for generating ATP. What you also don't realize, it's a key regulator for glucose-stimulated insulin secretion. Remember that insulin is only produced by the beta cells of the pancreas whenever there's a detection of glucose in the blood. Otherwise, your body does not produce the insulin. So how does this pertain to the pancreas? What we find is that when you have mitochondrial dysfunction, this contributes to pancreatic beta cell dysfunction, insulin resistance, and obesity and vascular complications. So at the end of the day, we need to go back to the basics, which is your mitochondria. Now, the thing about the mitochondria is it's very useful because it's very good for ATP generation. But as it does that, it gets exhausted, and it's one that's contributing to cell death, the apoptosis, and reactive oxygen species. Now, this is a double-edged sword. Why? Because as you develop your reactive oxygen species, this also causes mutations in the DNA of your mitochondria. So it's a vicious cycle. It produces reactive oxygen species as it's generating ATP, but this same species is actually attacking your mitochondria, and because it has poor repair mechanisms, this is accumulating with age, which is essentially what is happening in the pancreas. You get insulin resistance. What about in the obese patient? Why it's very key when we're talking about type 2 diabetes patients is most oftentimes they're obese. So what we found is chronic disuse of this muscle decreases your mitochondrial content and its oxidative capacity, its ability to produce ATP. So what we encourage usually is the aerobic exercise just to enhance ATP generation. But the more it does, the more it gets exhausted. So what have I said? Key is, we've always focused when we're talking about type 2 diabetes is we've never thought we could actually do anything much about your insulin resistance. We said, if you're obese, try and lose weight, try and see if we can be able to work on that by working on the obesity. The beta cell dysfunction, other than trying to see if we can be able to reduce the production of insulin by thereby lowering glucose, there's not much that we can do. What I'm saying is, why don't we focus on mitochondrial dysfunction and see if it is actually possible? So a need right now is a dual mechanism of action for a drug which not only increases insulin secretion in response to glucose, but it's also preserving your beta cell mass by improving your insulin resistance. And this is what we call imeglibin. So it's one of the glimins that was developed, and it's not very far from your metformin, and it's called a tetrahydrodiazine simply because with your metformin you had a dimethyl group. How here it's actually added another group. So what it's done is it has the actions of metformin, but even better because it has dual mechanism of action. So we had talked about, even when the gastroenterologists were talking about drugs, it takes a while before it's actually approved. So you can see it, when they started the phase 2 clinical trials, it was just to see the effect of these drugs, how it's being handled, and most of the trials were being conducted in Japan. It's only in 2021 that it's actually been approved. So let's talk a little bit about what's going on. So we know it is increasing insulin response, insulin secretion in response to glucose, and improving insulin sensitivity. How? By reducing the oxidative stress and improving mitochondrial function. And I'll explain how it does that. Bear with me. I know biochemistry is not the best, but please try and focus so that if a patient comes to you and they want an explanation, you'll know what we're talking about. Now, ordinarily, when glucose binds to the GLUT2 receptor, it undergoes phosphorylation to glucose 6-phosphate, which is converted to pyruvate. You end up with ATP generation. Very inefficient system because as you produce, it's like a factory. As you produce products, it's producing reactive oxygen species. So how about you come up with a salvage pathway? And this is the salvage pathway that we're talking about, where at the end of the day, your nicotinamide ends up producing an nicotinamide adenine dinucleotide, which is actually better in causing calcium release, and further insulin secretion. What are the implications of that? When you increase your NAD, it actually improves your beta cell function. So what it's doing is increasing your glucose-dependent insulin secretion, preventing beta cell death. So we are improving on the beta cell mass, and this is very important when you'll be dealing with patients who say you want to do reversal of diabetes, which Dr. Hilda is very passionate about, and it's also increasing your functional beta cell mass. At the same time, not only is it working on the pancreas, it's also working in the liver and the muscle. How is it doing that? It's reducing excessive gluconeogenesis and decreasing steatosis. So Dr. Murunga, wake up. You can actually maybe perhaps start thinking of using this drug in MAFLD patients. And in the muscle, it's increasing insulin signaling and enhancing glucose uptake for energy. So it's an exciting drug. So at the end of the day, it's amplifying your glucose-stimulated insulin secretion, enhancing its insulin action, but correcting your mitochondrial dysfunction. So what have we known from the trials? And we'll explain to you going forward from these trials that we've come across. And I'll explain to you how we got to 1,000 milligrams twice a day. Of note is it has very low protein binding, and that means in terms of drug interaction, it's very good. It actually does not induce or enhance cytochrome P450. It's excreted and changed in the kidneys, so I know the nephrologists will be curious to know what they found in the studies. And only problem we found is most of the studies were done in Japanese patients. So I'm hoping at the end of this talk, Dawa will feel inclined to give us some samples so that we can try it on our patients. Of note is that they advised you don't use the drug when the eGFR is less than 45. Of note is for patients with some moderate hepatic impairment, perhaps not. And we, of course, we've not done any studies on pregnant or lactating women. So let's go to the clinical trials. I'll try and make it a bit sweet, I think, if that's possible. So you know it's all very well in vivo to try this out, but how about if you actually tried it on patients? So they did an 18-week phase 2 efficacy trial where they were looking at increase in insulin secretion and improvement in insulin action. And what they actually found was imeglimin did better than, of course, placebo. Now, you want to be sure that this drug actually says what it actually does. So to assess the glucose-stimulated insulin secretion, they decided to conduct a double-blind, randomized placebo-controlled study in 33 patients. I know it's a small cohort of patients, and they only did it for 7 days. But what was our endpoint? It's to look and see at the first phase insulin secreting capacity. It was increased by up to 110%. And then prolonged, it's actually up to 29%. So we know it's increasing your beta cell glucose sensitivity. For me, I find it exciting because when I think of beta cell death, I feel very sad because every time a type 2 diabetes patient comes to me, my first conversation is, I'll start you on drugs, but you know eventually you're going to be on insulin. And I say it takes about 10 years. Now I'm saying it could take longer. So it's exciting. So then we went to a phase 2B trial, and I'm sure you've got all these studies with you, but I'm just going to summarize. So it was an efficacy and safety of imeglimin in Japanese patients with type 2 diabetes. It was for 24 weeks, it was randomized, double-blind placebo control, and this was just to look at the dose. Remember we had said the ideal dose is 1,000 milligrams. So what they did was they assigned patients to either 500 milligrams, 1,000, 1,500, or placebo twice daily over a 24-week period. What was our primary endpoint for diabetes? You know, at the end of the day, it's HbA1c. And that's why the initial trials done by Fokore and Pirag had only done about 4 to 12 weeks. So they couldn't really talk about effect on HbA1c, and that's why we had gone to a phase 2B. Now look at this. At a dose of 500 milligrams, it reduces it by 0.52%, okay? But at 1,000 milligrams, 0.94, and at 1 milligram, 1%. That's quite exciting. However, what you find is that, you know, the higher the dose, likely side effects. And that's why at the end of the day, there's not much difference between 0.94 and 1%. And yet, you know patients in terms of compliance, if you're going to give them more GI adverse events, then you'd rather stick with your 1,000 milligram dose, and you take it twice daily. And then this formed the basis for moving on to your phase 3 studies. So the only 3, they're easy to remember, times 1, 2, and 3. And I'll explain what they did subsequently. These Japanese are quite smart. So it's called trials of imeglimin for efficacy and safety. Now, in the times 1 trial, it was a randomized, as always, double-blind, placebo-controlled monotherapy. You want to see 1,000 milligrams of imeglimin twice a day against placebo for 24 weeks in 213 patients. And you want to see its effect. Endpoint is HbA1c. And you can see that it was actually in a real population minus 0.87, almost similar to metformin. So you ask, so then why? But remember, it has dual mechanism of action. Preserving your beta cell mass, reducing your insulin resistance. So now we've known 1,000 milligrams twice a day works, right? Then you move to times 2. Now times 2, the previous one was 24 weeks. We moved on. Let's say let's try it for a year. 52 weeks. But now this was open label, parallel group, and about 714 patients. And they were given twice daily 1,000 milligrams. We wanted to see if you combined it with other drugs, does it make a difference? Is it going to help? And then number 2, if you have combined drugs. So of note is, okay, we don't usually use acarbose, but there was 0.85 difference. Then we had the biguanides. When combined with metformin, it was 0.67. What was surprising was in combination with DPP-4s, it was actually as high as 0.92. And what they postulated was you have different mechanisms of action, so you're getting better control of your sugars, and they didn't experience any hypoglycemia or side effects. With the glinides, SGLT2, not much difference. So at the end of the day, they said you find robust efficacy benefits when you combine with a DPP-4. So when you start seeing them combining with DPP-4s, don't be surprised. So we've known about monotherapy in times 1. Times 2, we've talked about combination. But the most important thing is, does it cause hypoglycemia? And so what they did when they went to times 3 was combine it with insulin. So it was a 2-phased study. So the first one was 16 weeks, double-blind placebo-controlled trial in 215 patients. So initially, you were randomized to either insulin and imeglimin, 1,000 milligrams twice a day, or insulin and placebo. And then thereafter, if you were able to, then we moved you on to your second phase for 36 weeks, where it was just purely insulin. And what we found was there was still a difference in the HbA1c, not much, but it's still safe to combine with insulin, and they reduced the HbA1c by 0.6%. But what were we looking at here? The primary focus was that we did not have any hypoglycemia. But of note also is that in the initial 36 weeks, you had a reduction 0.4%, which increased to 0.6% when you are done at the end of the 52 weeks. Remember, no hypoglycemia. For a patient, that's quite deadly. For the nephrologists, I'm sure you're curious about whether its effect is good in the kidney. They only felt it was safe enough to use up to stage 2, and you found reductions of between up to 0.64% for stage 2, and for stage 1, 0.2%. So you're still having an effect even with stage 2. Now, the common thing we keep talking about, and what we've realized, when we manage our type 2 diabetes patients, you find someone comes with a very good HbA1c, and you're excited. But the patient is presenting with signs of peripheral autonomic neuropathy and diabetic retinopathy. What we realized is that when you keep having fluctuations of your glucose, what happens is this is contributing to production of advanced glycation end products. And that's why you're having complications. So we introduced a concept called time in range. And we said if you maintain your glucose levels at a certain level, at about 72% of the time in the day, then we know that if it correlates with your HbA1c, the patient is compliant and we're managing. So this is what they wanted to evaluate. If we do continuous glucose monitoring, is there effect? And we found before imeglimin, ranging 8.9 millimoles, after 7.8. But what was even more exciting, you moved from a time in range of 69.5 to 82%, so even surpassing our expectations. So that's quite exciting in terms of that. So what have I said? Metformin will still be a good drug, but what we found is with imeglimin, one, it enhances glucose-stimulated insulin secretion, and there's evidence of insulin sensitivity. What does it translate to? Preserving your beta cell mass, reducing your insulin resistance, preserving your mitochondria, and at the end of the day, it contributes to even more efficacy. We can't talk much about its CV safety, but of note is it's been known to inhibit your mitochondrial permeability without affecting your mitochondrial respiration. What does that mean? It's safe in terms of patients with cardiac disease. Most of our diabetic patients also have hypertension and obesity. So they wanted to try and push the gun. And they want to see if this drug is safe. So they gave very high doses, imeglimin 2250 versus a dose of 6,000 milligrams, drugs that are known to cause prolonged QT, like moxifloxacin, and they found it was safe. It does not cause or induce a prolonged QT, so it's relatively safe. So what have I said? Metformin is very nice. It enhances or improves insulin sensitivity. Our sulfonylureas cause beta cell stimulation, they produce insulin. Same with the DPP-4s. But now we have a drug that not only enhances insulin sensitivity, stimulates beta cells while preserving it, and it also acts on the mitochondria. So at the end of the day, what is my take home? It's the only oral compound with a dual mechanism of action. And then it's targeting 3 organs, which we've not had in all the other drugs, the pancreas, the liver, and the muscle. And it's shown to have a positive impact on skeletal muscle glucose uptake, hepatic glucose production, and it's reducing your beta cell apoptosis. For me, that is the thing that is very exciting. And it's been shown it has good efficacy, whether it's monotherapy or in combination with drugs or with insulin. So at the end of the day, I think it's an exciting drug. The only thing, of course, is that most of these studies were done in Japanese patients. So I have not presented any trial in Kenya, I apologize, but we're hoping, we've talked with the DAWA team that they'll give us some drugs. So anyone who's seeing type 2 diabetes patients, it would be a good idea to actually try it out on our patients, and then maybe we can present the data next year, same time. Thank you very much, and you can now wake up.
Thank you very much, Dr. Roslyn. I think Dr. Roslyn is one of our best presenters because she has saved us a whole 10 minutes, and we are very grateful because today is packed, but we still move on. So I would like to welcome Dr. Wanyoike to have a presentation, and I'll ask Dr. Eric Njenga to introduce him, and then thereafter he will moderate the Q&A session. Thank you.
So thank you, everyone. So we're going to have Dr. Martin Wanyoike, who is going to do the next presentation. And he's a consultant physician, cardiologist, based at the Nairobi Hospital. He's been practicing medicine for close to 40 years. He was previously working as a physician, cardiologist, Nairobi Heart Clinic, and also in Karen Hospital previously. He had his training with regard to cardiology in Netherlands, India, USA, and South Africa. He was previously section head of cardiology in the Department of Medicine, Nairobi Hospital, and is currently in private practice at Prime Care Heart Clinic, which is based at the Nairobi Hospital. So thank you so much, Dr. Martin Wanyoike. Thanks for making time to come for KAP. And he'll take us through this particular talk about optimizing heart failure treatment in the setting of reduced ejection. Then from there, I'll moderate the Q&A for the 2 talks by Dr. Roslyn and Dr. Martin. Thank you.
Thank you, Dr. Njenga, for the good introduction. Of course, the challenge when I'm the doctor and you're just in a pretty energetic, full of passion lady talking to us, but I hope to keep to the task. So the topic I first thank Kenya Association of Physicians and Novartis for inviting me for this presentation. For myself, I'm a practicing clinician, We have many people who met us every day in Nairobi Hospital, one of them being our patron. I know even another one called Dr. Max Okonji, who always say that we're in the working class, we are just working. And when you are working, we try to do our best to make sure that we get the patient good outcome. So when you talk about goal-directed medical therapy, it is what we try to practice all the time. But we get challenges because when you are just using the guideline-directed medical treatment, you are a little bit updated. Because as you are going to see, one of the latest document on that is from the European Society of Cardiology. And when this one came out in August last year, they were even stating it very clearly. This is up to the data of March 2023. And now when you're in 2024, already what we are pressing is outdated. But we know ourselves is that if you are a Muslim and you want to go to heaven, you read the Quran. If you are a Christian, you read the Bible. So the guidelines, at least you have a direction of where to go. And of course, we are very busy. We are not able to actually read the latest article yesterday. But with the guidelines and also ensuring that we are also young tax within us, we are able to move on. So that is a slide which was required by the sponsor. So that one you don't have anything to say, and I'm sure you have already through it. And of course, in Prime Care Heart Clinic, we believe we have a passion for actually mentoring young people. And this is what I was taught many years ago by Dr. Gekonyo. And one of the things which was very interesting was that I was thought I was the best because Gekonyo mentored all of us from Yonga to Robert Mathenge, Githegi, many of us, Karari, all of them were working at Nairobi Heart Clinic. And me having worked for 16 years, I thought I'd worked the longest. But in our practice, we have joined by Dr. Atibu, who had worked with Mathenge for 19 years. So that one has broken the record. We tried to bring the face of Kenya, but the association number 4 also is from the family because that's my daughter, who is a physician. So we try our best that we phase it out. I saw Kelvin was around. We have Dr. Mora in Scotland now studying cardiology, and we're hoping to join us in September. We have Dr. Derito in Baragwanath Hospital. I was with him 2 weeks ago, and he's doing cardiology there. We had tried to mentor Motura, but he was snatched by the gastroenterologist, and we accepted, and it is good, and we work with a lot of passion, and as we are here, life is still going on where we are. Of course, nothing to say about that one. So, of course, this is those ones who really want to practice medicine well. Guidelines are there, like that 2023. If you read it, you practice heart failure the best. And of course, what is challenging us as cardiology now is to diagnose heart failure with preserved ejection fraction. But this document from the American College of Cardiology speaks it all. It is so simplified that all of us now can be able to diagnose heart failure with preserved ejection fraction. We do not have a lot of passion for diagnosing it because the drugs which are only available are diuretics. But now we have sodium glucose reuptake 2 inhibitors in this condition, so we should not miss it. Then, of course, these others, of course, the ESC was updated, ACC is there, and the new kid in the block on heart failure is glitazones. And if you want to really understand it well, this article in the New England Journal of Medicine, you read it, you remember your physiology in the second year, and you like it. So, of course, about whether it's level 2, 3, or 1, it is when it is green that if you're not using what is green, you are like probably supposed to be taken to court because you are medical negligence. Of course, this is a slide which was given by Dr. Gekonyo when I joined him in 1993, the qualities of a good doctor. And of course, when I was coming here, I know I'm going to meet young physicians. If you really want to be a good physician, you must have those 3 A's. All of you scored A's who did the scoring of A's. And the most important than of it all is to be charming. You must charm your patients that you are able, you are affable, you are available. And of course, you know, if you are a doctor, the word doctor means to be a teacher. And the Holy Scripture says all. I can see Paul Wangai here and the wife. Wangai was my classmate. That the Holy Scripture says it's all about serving others. And if you really want to be a millionaire, whether in medicine or everything, it is serving others. And that is there in the Holy Scriptures. So, of course, now we go to serious business. We define heart failure. Heart failure's definition is very simple. Structural or functional disorder of the heart resulting in the inability of the ventricle to fill with blood that is heart failure with preserved ejection fraction, or unable to inject blood, that is heart failure with reduced ejection fraction. That's the topic of today. Remember, there's also heart failure with mild reduced ejection fraction, which is not even a topic of today and is not put there in the definition. And for the heart failure, we must remember that is a serious public health challenge with a lot of morbidity, mortality, and that 50% of people with heart failure, they die within 4 years. Those ones who are in New York class 4, they actually die, half of them die within a year. Very bad outcome, worse than the many cancers, and to be taken very seriously. Please note that when you diagnose one patient with heart failure with preserved ejection fraction, there's another one with preserved. When you see an EF less than 40, there's another one who's more than 50, who is also the same. And we are missing them all the time, and they need to be picked so that they can be managed appropriately. When we are treating heart failure with reduced ejection fraction, we know to reduce the symptoms, we improve quality of life, we want to decrease morbidity and mortality, and we also need to reverse the process of adverse remodeling of the ventricle. We know that when we finished medical school, and Professor Ogola was my teacher, and we were the Merawangai in the same class. 1987, what was therefore available for heart failure is Lasix and digoxin. In 1987, that's when they did that consensus study, and Narapil came to the market. And we have done a lot of evolution, and you're going to see, we are going to talk about the 4 pillars, where even things are even getting improved every day, and even new novel agents coming to place. One of the take-home messages in the ACC guidelines is this one saying that guideline-directed medical therapy for heart failure with reduced ejection fraction now in the 2022 includes 4 medication. And these 4 medication are the ones we say 4 pillars, and that includes sodium glucose or transport 2 inhibitor. And these are the pillars. Of course, this slide was given by Novartis, but actually the 4 pillars does not include the diuretics. The 4 pillars is those renin-angiotensin blockers, beta blockers, mineralocorticoid antagonists, and you know we are now having a new one called phenylalanine, sodium glucose reuptake inhibitors. Those are class 1, as you can see, that when you're not giving a patient those medication, then you are at risk of giving medical negligence. And these are the ones. In the ACE inhibitors, we have them as listed there. We have the angiotensin receptor blockers. These are the ones which have been done in trials of heart failure. There is now that other one which came in 2014, the angiotensin receptor neprilysin inhibitor. And we're going to talk a little bit about how the pathophysiology of that came into being, that we realize that these are agents which can help us. Beta blockers, you know, they came in the 1990s. We have the mineralocorticoid antagonists. You know the rare trial in 1999 where adactone was shown, but naproxen came in, and mineralocorticoid antagonist side effects were less, and phenylalanine is even better. Then these sodium glucose reuptake inhibitors, the psychologists call it serendipity, because it is where you get good discoveries when you're trying to achieve your goals. And you know, it was just the trials of drugs for new diabetic medication. Do they harm the heart? And they benefit the heart so well that now we went to the studies where we are studying them when patients don't have diabetes, and the benefit was real. So going on, of course, this is the 2023 guidelines of the European Society of Cardiology, the update. And this is a very important message, that intensive strategy of initiation and rapid application of evidence-based treatment. These are the 4 pillars. Before discharge. So we want patients who have heart failure with reduced ejection fraction. By the time they leave hospital, they have a beta blocker, they have sacubitril valsartan, they have mineralocorticoid antagonist, they have glucose reuptake inhibitor, 4 before they leave, in 4 dosages. And then we are aiming that by 6 weeks, we are actually getting to the full dose if we can. Of course, I saw that somebody posted this slide, and I was in Nairobi, I saw it, and somebody was saying that, remember, when you have a smoker, and when you are overweight, you are already in heart failure stage A. And this have been done. That's American way they classify it. We say that if you're at risk, if you're having hypertension, you are smoking, you are not exercising, you are in stage A. And then stage B is when you are in pre-heart failure, where you have structural abnormality, but you have no symptoms. The topic of today is related to the stage C heart failure, symptomatic heart failure, previous or present symptoms of heart failure. And this is why you categorize them into 2. If the EF is more than 50, heart failure with preserved ejection fraction. If the EF is less than 40, heart failure with reduced ejection fraction. And you're going to see the other phenotype as we go along. In Kenya, we don't do very much on this part of stage D because that's why you're using the mechanical devices. We are doing transplants, and we are hoping it will reach there in time. So this slide, probably the most important, is note that there are also categories of patients who we refer to as heart failure with improved ejection fraction. And these ones need to be managed also in a particular manner. The temptation to stop the medication, studies have turned and they were shown that stopping medication does not work well, but there are some categories of patients where they do well when they have improved. We know that even when you use CRT, they say that about 80% of the patients actually improve their EF very well, but the super responders where the EF goes above 50% is probably about 10%. And those ones, probably you may stop the medication. And I know one of our patients who actually put the CRT, we actually stopped the medicine, and as we are monitoring, the EF has remained normal. And but generally, patients are advised to continue the medication. So, of course, we are clinicians, and you should always remember 10 points when you have a patient with heart failure reduced ejection fraction. Establish a diagnosis, determine the etiology, identify the precipitating and exacerbating factors. They're usually there. Prevent progression of disease, reduce mobility and mortality. Assess complicating factors, consider device treatment, manage comorbidities, exercise rehabilitation. This is class 1 today. Exercising, we call it a polypill because it is benefiting you in many ways, like when you put, of course, know that what brought me here, but when you use this X4HT, 3 drugs in one, the exercise is a polypill. Monitor progress, and then counseling the patient thereafter is very important because many of those patients, many of them are going to stage 4. You must give them the natural history so that you're all moving together. This is one of the precipitants of heart failure symptoms, and this is atrial fibrillation. All of us are able to recognize it when you have an ECG, irregular, there is a pulse deficit, and an ECG says it well. And you know that when you have atrial fibrillation, you automatically reduce your cardiac output by 30% because the atrial kick is lost. Many of the patients nowadays, we want them even to go to do a rhythm control so that you're taking them to the sinus rhythm. And that sinus rhythm, now you overcome that problem. And of course, there is those aspects of anticoagulation and all that, and what's coming, the guidelines. So this is the phenotype. The EF40, mid-range, preserved ejection fraction. I don't need to say I did anything about that. This is the Framingham criteria. Very simple also to diagnose heart failure because you have 2 major criteria, or 1 major and 2 minor. And these are easy to pick in your patients from your history physical examination. I know we are not doing very well in physical examination, and I think that initiative by Professor Joey is very good for all of us so that to improve our clinical skills. Remember that 80% of the diagnosis is made from proper history, and that part of the examination is where you do, and the labs say 20%. So proper history is very key. And of course, these are the symptoms of heart failure. You don't need to do that one, symptoms and signs. That one is obvious that this is somebody with probably neglected, not managed well, and not doing well. And this is an algorithm of diagnosing heart failure. You start with somebody who has suspected heart failure. Look at the risk factors, symptoms and signs. Abnormal ECG. It's very unusual to have a patient with heart failure with a normal ECG. It's very unusual. And obviously, like in a clinic like ours, where we have actually 2 ECG machines, we always say that if the patient cannot even afford it, you do it free because it will give you a lot of information. All the patients, like ourselves, is a baseline in the file. And you want to do it like an annual checkup because many of those atrial fibrillation, they are picked incidentally. And of course, there are those pro-BNP. We are not able to do that even in Nairobi Hospital. Pro-BNP, before the dollar crashed, before the Kenya shilling crashed, it was costing 8,000. I don't know how much it's costing now. And it is really a challenge because we can't do pro-BNP the way we want because of the cost, because that you're not, the patient may not even be able to buy the drugs. Of course, echo is the key. Echo is very important. Then, of course, when you do your echo, you do the phenotyping, and you may have now those 3 categories, and you have diagnosed heart failure. These are the basic tests. I don't need to go through that. Pro-BNP, ECG, echo, chest X-ray, routine blood tests. These are obvious for us. Of course, remember the saturation, iron studies, so that you can identify their own deficiency, so that you manage appropriately. This is the take-home message. This is the most important slide in the talk. And if you take this one in, you have it all. It is from the European Society of Cardiology Guidelines of 2021. That they are the 4 pillars are those 4. You either use an ACE inhibitor, an ARB, or a sacubitril/valsartan. That is one of the pillars. The other one is a beta blocker. The other one is mineralocorticoid antagonist. The other one is sodium glucose reuptake inhibitors. When the patient is congested, I was just dealing with a patient. Actually, I was seeing this patient at 10 p.m. yesterday in one of the wards in the hospital, in Nairobi Hospital. And this lady was so congested, she had actually was sleeping seated. And what we needed was diurese. And I gave her a very generous dose of diuretic. And when I was coming on the way, I was asking the nurse, how is the lady doing? And she was actually very happy because she managed to sleep better. Other than the peeing many times, she was already better in the morning. There's the issues of the devices, and probably that you know discuss a lot. And there's the issue of ivabradine. When you're using hydroxyzine, isosorbide nitrate, when you're using the transplant, that is, of course, we are saying you're not doing very well, but you see the exercise is green, yeah? So that when you're not encouraging patient to exercise, you're not of that giving them negligence. So we present a case so that we saw what we have been doing. And this is a lady, in fact, 55 years old, and she presented in 2015. And those were the complaints there. And we diagnosed her eventually that she has heart failure with reduced ejection fraction. And this was the physical examination. Not the ECG was LBB, and I'm going to show her ECG. It is reported that those people with reduced ejection fraction, heart failure with reduced ejection fraction, 30% may have LBB. And LBB is one of the things which you use for device, as we did in this patient. This is ECG, of course, I've actually copied from the file, from our file, and those ones who are astute clinician, you see that the V1, it is down once, it is wide, and as you can see, the QRS duration is 165. We have patients requiring CRT, as we're going to talk about, when the QRS is more than 150. This was 165. And of course, this is just to remember about the LBB, and obviously this one is just a way to pick it. And that's an ECG of it. This is right bundle branch block, and that's the way to pick it. And ECG, of course, is one of the things which even Kenya Cardiac Society is giving us webinars. This is a patient in 2015 when she came. You see, the echo is global hypokinesia, very poor LV function, EF 15%. So this is a patient whose EF is less than 40, heart failure with reduced ejection fraction. Because there was that severe MR, severe TR, the LV was dilated. She had been known to have hypertension before. She had that pulmonary hypertension as a part of the heart failure. And I don't know whether that slide can, whether the video can run. I don't know whether those people helping us with IT can make it run. I don't know, because this is an echo showing you an echo with normal. Can somebody run the video? Yes, this is running. So this, fortunately, in our clinic, we are invested quite a lot. We are not recognized as our colleagues who are given medals. We don't mind, but we have in our clinic 7 nurses. One of them, we call her cardiac physiologist. She's an echo. She actually was working in Bukaki before, and she's so much passion of the echo that she actually does for us. So this is an echo, straightforward, normal ejection fraction, normal LV. And as we go along, I didn't actually, because 2015 we are not, can the video run again? This is a normal echo LV function. Of course, we can pick it straight away. This is an EF of more than 60. And then we go to the other one. Now this is the one now with poor ejection fraction. Just run it. Of course, it's a spot diagnosis for the cardiologist. When you see an echo like that, even being done by somebody from far, you can, this is an EF of 20%, 15%. You can, we call it eyeball. Of course, you're not encouraged to do that. You're supposed to do volumes and do the EFs, and that is that way. Then this is the other one. This just run it also. Parasternal long axis called it. This is an EF of 20%, 15%, like that patient. And the same patient we are continuing. This is the lab test. Nothing much on it. And this is the time now, because we even admitted at that time. This was the discharge diagnosis, the medical report we make. We have passion for making medical reports. That any patient you see have done an echo, require medical support. This was the discharge diagnosis: hypertension, cardiomyopathy, hypertension, left atrial branch block. The QRS duration was 65. She had type 2 diabetes mellitus. She had uric acid was high. She had elevated cholesterol and has also elevated body weight. And now this is the discharge medication. This is what she was sent home on. That is candesartan. That's what we used to use from AstraZeneca that time. We didn't have sacubitril valsartan. She was on aminocorticoid antagonist. You know the Rayo study of 1999. It was one of the class 1. Beta blockers were there, and we had 3 beta blockers. He was on metoprolol. She was congested. She was on thiazide diuretic. No, not thiazide. She was a loop diuretic. Digoxin, of course, we were using it. That's what's available. Prochloride was also available, and these other medicine for her comorbidities. And of course, us, as we learned with Dr. Gikonyo, Dr. Aluch is also a passion for it. These patients who have heart failure, who have diabetes, who are more than 65 years, we want them to be on the flu vaccine, and also with the pneumococcal vaccine. So this is the patient continuing. Now she comes, she's doing very well. She's a teacher actually in Kisii, a primary school teacher, very passionate to her work. She comes now in 2021, now in heart failure again. Very unwell in new class 3. We admit her, and the husband is also a teacher. There's no money, and we diagnose the EF is 22%. And fortunately, that time, Moditronic, we had a visiting team from Egypt who are doing the electrophysiology work, and we managed to talk to them and they donated for us a Medtronic CRT device. And she was actually put that device. This is 25th February 2021, and we did that, and this is, she continued and actually improved quite a lot to be able to send her home. And when I was seeing her file, because I was presenting, I looked at this file and I saw 2017, July, the last time she was seen. So I called her and I asked her, what is happening? And you know, we are supposed to every 3 months. So doctor, you know, I go so well, I was marking these exams. You told me never to stop this medication. I never stopped them. I'm milking my cows. And I'm sending so many people from Kisii to your place because they are so happy with me as I'm a living example. So we actually talked to the Novartis people because they're asking us for patients who can be advocate for medication. And actually she's very ready to help in advocating the wellness. And we also talked to the Medtronic people because they actually donated this device for her, that they can also tell people how those devices help. So this is the ECG now with CRT. You can see these spikes are called pacemaker spikes. The QRS duration has reduced to 137 from 165. We of course, the Novartis people say the Europeriod over there, it was actually on it before. But that 2021, what made the difference in this study in our view was the device. Because after the device from New York class 3, she has gone to class 1. And this is now, when we saw her in the file the last time, these were the medicine she was on. She was on sacubitril valsartan 200 milligrams twice a day. She was on Bivolo, Empiget. She was on Adaction, and she was also on some statin. Of course, one can criticize somebody with heart failure, may not be given statins, but these are only guidelines, and we have also something you also decide about yourself and the patient. Then the other things, of course, she has also a bit of that mild asthma, and the flu vaccine she has been taking regularly. So now we go to the serious business. I don't know how much time I have. How many more minutes? Do I finish now? No, heart failure, you can do the whole day. How many more? Maybe I don't know. So this is a heart failure. This is a patient with LVH, 5 minutes. LVH, and this is a patient with hypertensive heart disease. We are told that hypertension is the most common cause of heart failure with reduced ejection fraction in Africa because we don't do very well. Professor Ogola has done so many work on this. He even told me that probably the catch of capturing and getting the right dose targets of pressure is probably 10, 20% or 30%. This is, of course, the LVH, you have to be very fast. And of course, the pathophysiology, we may not have time of all these things about preload and everything. But remember, this is a vicious cycle of heart failure where when the ventricle dilates, you get more mitral regurgitation, more stress by those Laplace law, and you get what the lady was talking about, apostosis, fibrosis, occurring in the ventricle, leading to arrhythmias, red band stroke, and death. And these are the hormones which are increased in heart failure. And the pathophysiology of heart failure reduced ejection fraction has been very clear to us for many years. And that is why you were able to get those 4 pillars and generated the medication. And these are the chemicals which are there, epinephrine, renin-adjacent enzyme, antidiuretic hormone, adrenaline, tumor necrotic factor. They are all harming the heart. But there are those ones which put brakes. And those which put brakes are ationitrutic peptide, B-nitritic peptide, C-nitritic peptide. So drugs like sacubitril valsartan, what it only does is that it stops the breakdown of these beneficial chemicals, and that also improves the heart. And that's why you got all these other. So the nitritic peptide system protects the myocardium. So when you get a drug which increases their levels, the heart is liking it. So there are those many good things which are happening, the vasodilatation, the hypertrophy and proliferation, anti-apoptosis, all those bad things which happen to the heart. When you increase those chemicals, things get better. And so the nitric peptide system benefits you. The sympathetic, the angiotensin harms. And so that is why now we have all those drugs manipulating the hormones, and eventually now this study in 2014, the angiotensin neprilysin inhibitor versus enalapril. This is the study which was done, and this is the study design which we may not need to go to the details, and I'm sure this has been discussed many times. And this is the Mayer curves, and that is what happened, and things work. So this is SGLT2. We may not also not go about it. I'm sure this you have seen many times, how sodium glucose reuptake 2 is in the proximal area. There is the 10% in the distal area. Blocking that, you lose a lot of glucose in the urine, and that causes a lot of beneficial effects, very many. It was discovered by accident. Not by accident, I think by just God helping us. And these chemicals have been very good. Of course, that's the topic of today. These are the drugs you're saying, the class 1. And of course, this is about the digoxin. Postpartum cardiomyopathy is also there. I get very excited because that Karen Siwa, we are studying with her in Baragwanath. Now she's a professor in Cape Town. Me, I'm just a simple doctor in Nairobi Hospital. And it is okay. But she's the one who reads on this cardiomyopathy. It was one of our teachers in Baragwanath, also called Professor Sared, who had so much passion about this peripartum cardiomyopathy. They have done a lot of studies. When you go to those conferences, they are presenting and you are listening and you don't mind. Because there are many things about this peripartum cardiomyopathy, but remember bronchectin use is useful, and there are 2 dosages you can use. And the thing are there, those are about the devices. You have to move the speed of light. About these are the malignant arrhythmias. These are the devices, and this is Elbrand block. This is the CRT, where you have to put 2 wires to the heart. It is quite a process. When I saw it being done first time, it was in Miluka Park Hospital by a doctor, a professor there called Professor Obel, not the one of ours. There's another one there, a electrophysiologist, who is a Muzungu, and he could do it for even 6 hours. And that time he could even advocate thoracotomy because the wires were very complicated. We are doing them in Nairobi Hospital, and we have people who have we have good experience, but of course you need to be very patient because we are saying that in cardiology you have to be really humble because you may be struggling with the case. Then Professor Ogola comes and just does like this. Then you just see the nurses are just looking at this arrogant doctor. Yeah? So we are forced to be humble. So this is the process. You have to cannulate the coronary sinus. You have to do an venogram on it to identify the most lateral vessel so that you can put your device. This is the CRT making out of difference, like that patient. This is the exercise. You are coming to an end. And this is the take home. This is the polypharmacy in heart failure. It is inevitable, and the slide is here. The take home message, the 4 pillars, diuretics, devices, ivabradine, atrial fibrillation we manage very well. TAVI is also there as green, and cardiac rehabilitation, remember. But the final message is this, ladies and gentlemen. This is the Holy Scriptures all the time. One guy was reading for us when we were in medical school, and we all need one another, multidisciplinary team in heart failure. Just like our body parts, the eye cannot say to the hand, I don't need you, and the head cannot say to the feet, I don't need you. On the contrary, those parts of the body that seem to be weaker are indispensable. Nimemaliza.
So thank you so much, Dr. Martin Wanyoike. So I'll invite our 2 speakers to come on stage. Please, ushers, let's have the seats on stage. And kindly, the mics, where the ushers, let's have the mics going round. So it's 1:15. We'll only have 5 minutes of Q&A so that we can be able to save time for lunch and catch up with the afternoon program. But they are here for lunch, so in case of anything, you can always catch the speakers. So please raise your hand and ask your question.
Thank you, Dr. Wanyoike, for the presentation. My name is Dr. Bundi from Meru. Sometimes we see patients with heart failure with reduced ejection fraction. After treatment, the patient recovers. and subsequent echoes, you find an EF of 60%. Do you withdraw the medications, or, for example, this lady with so many drugs, at one time she will say she is tired with the drugs. What will you do? Thank you.
Yeah, that's a very good question. In fact, it was one of the slides which I put there when I showed the phenotype and said that as you're having the phenotype of heart failure, we have those ones who are less than 40%. So you say they have heart failure with reduced ejection fraction. If ejection fraction between 41 and 49, we say they have heart failure with mild reduced ejection fraction. And those ones who have symptoms and signs of heart failure and the EF is more than 50, we say they have heart failure with the preserved ejection fraction. Then there was a phenotype we called heart failure with improved ejection fraction. This is the one we say that your EF was less than 40, you have improved by more than 10 points, and you're more than 40. So these are the one we say heart failure with improved ejection fraction. And that category, we actually find when you CRT, many of the patients, and I know the first one we did, we are doing with people from South Africa. They would come and do a CRT. Now we're able to do it ourselves. And this man was also on those polypharmacy. And as it happens that in our practices, actually, in my office, we have 2 echo machines working. And we usually say that when the patient is there, if you are not, of course, it is probably spoiling young doctors, but the machine is there, you see, and then you can make a decision. So this one we did serially and stopped. So the recommendation is very clear. Ideally, those patients who have improved ejection fraction, the guidance says you continue with the medication. Because the studies were done showed that they actually relapse. We say that's a remission, not recovery. And when it is now not recovery, then the medicine to be continued. Because the studies were done, and they were shown that within a short time, they deteriorate. But as I said, there are those conditions which they are known that actually they can be sustained, can be stopped. I don't know whether any of you have ever diagnosed Takotsubo. We had Dr. Njao with us, and we had one patient who had surgery and had very severe chest pain. The troponins went up, and when we did the echo, we actually said, this is Takotsubo. Those ones recover, and actually that patient, we're still following her up in our clinic. She's not on any medication. If you have tachycardia-induced cardiomyopathy, say, an example is like you have atrial flutter. Atrial flutter, we know cardioversion helps. We know you can do catheter ablation, and there are people doing it. Dr. Ndwiga, I was with him yesterday and told me SVT flutters is able to handle. We have Dr. Salim in Mombasa. And if you have a patient who has tachycardia-induced cardiomyopathy because of atrial flutter, you treat that one. Actually, the EF, when it improves, it's not going to reverse because it's a reversible cause. It's very rare. You need to be very careful. In the study of the CRT, as I mentioned in the talk, about 10% are super responders. And those super responders get an EF more than 50. And those were the one you may consider, but you really need to monitor very closely because improvement EF is a remission, not cure. But of course, also peripartum cardiomyopathy is another category. When you have patients with peripartum cardiomyopathy, about 50%, 40%, depending on the regions of the world, the EF recover. But even those ones, when they recover, it's recommended to maintain those medicines at least a year before you start withdrawing. But we can start now withdrawing slowly with the time, and we have been doing that with our patients.
This is Dr. Ward from Kisumu. One question to Dr. Wanyoike, one to Dr. Roslin. Dr. Wanyoike, we have a very sick patient with heart failure, bradycardic, and also has diabetes, has bronchial asthma, COPD, peripheral vascular disease, all these relative contraindication to beta blockers. How would you make your decision about the 4 pillars of management in relation to adding beta blocker on board? Dr. Roslin, the question I wanted to ask is in relation to combination therapy, imeglimin. Forgetting about the mitochondrial dysfunction, one of the things you mentioned, of course we know, is that it actually acts via glucose-mediated insulin release. It enhances glucose-mediated insulin release from the pancreas. Then if you are combining it with a GLP-1, I mean an incretin, aren't you seeing that this is not exactly what we refer to as combination therapy, because GLP-1 also does almost exactly the same thing? Thank you.
Because I've talked too much, let me give her a chance to talk. Democracy.
Thank you for your question. So the main mechanism of action was we were targeting mitochondrial dysfunction, and as a result, one, we were preserving your beta cell mass by, one is, you're right, glucose-stimulated insulin secretion. So you're making it more effective. So you're working at two different levels, and I want to explain why. And that is why GLP-1s and DPP-4s were found to have be a better combination and reduce your HbA1c better. Now, at the GLP level, it's mainly acting at the intestinal level, where it is only when it senses the elevated glucose level that you find insulin secretion. But here we're working on the concept of reducing your insulin secretion resistance by making it smarter. You require less insulin for the same amount of glucose that you'd require to push it into the cell. And that's why they postulated, part of the reason why it works very well with DPP-4s is that your DPP-4s work at the intestinal level. This one is working at different levels. One, at the pancreatic level because of the mitochondrial dysfunction. Number two, also enhancing glucose uptake in the muscle, and at the same time in the liver, decreasing gluconeogenesis. So there is a synergistic role, but also an added role. I hope that answers your question. Thank you.
I can apologize. I just used to talk when standing because that's why I feel better. Now, the question about the beta blockers, it was actually answered in the patient we saw here, because the one I presented, remember, she is also on Symbicort. She's asthmatic also, and she takes inhalers. When you have talk about the beta blockers known to help in heart failure, we have Carvedro, which is non-selective, and that one is actually contraindicated in asthma. We have metoprolol and also bisoprolol. And those ones also, they have a little bit of that beta-1 effect. When you are giving actually beta blockers, even for hypertension, not that we like the people who make Bivolo, we actually like it a lot because it's the most well-tolerated beta blockers. If you look at the guidelines on heart failure and patients who have COPD and asthma, actually the beta blockers are not contraindicated. You only told to be cautious, and Nebivoro is the one we use, and that's what this patient was on. So patients who is having those COPD, asthma, and require beta blocker, Nebivoro is very well tolerated, and that patient was already on it. Then the other point is that you also need to make sure that part of the patient education, the last one, we do it very well because, as we have said, the people who are stage D heart failure in Kenya, we have very little bit to offer. We have very little to offer because sometimes you have that patient is in cardiogenic shock. He's on all the drugs. In fact, you are forced to withdraw because the pressure is too low to give even a beta blocker, too low to give even soquibutol for Satan, and you have to maintain them on inotropes. And those are patients who, when they are Western countries, they are given those ventricular-assisted devices, which don't have. They are the candidates for transplants. We have so many hearts which are wasted in this country. Even the legislature has not allowed it to be done, and we are also not even having the competence to do it, but I'm sure with these initiatives we are having, that will be done. So we must accept that patients with heart failure, they're in a journey. And that journey, when they go to stage D of heart failure, sometimes you just have to do the counseling and let them accept, because sometimes you may put them into a situation and you don't want to put a patient in the ICU because they can afford it for months and months on a ventilator, and then they're eventually going to go. So the counseling part is where you need to also reach a point that you let go, just like those stage 4 cancers, that patients with that way, there are some you cannot do anything because you don't have ventricular-assisted device, because you don't have heart transplant facilities available. I know when you used to work with Dr. Ikonyo, there's one man who came from Zambia and told us he wanted to actually be done kidney transplant. He told me, I can afford it, help me. And he was sent to South Africa and he was given transplant. But we know that transplant, even those centers, they do it's only available probably about 5-10%. I mean, 2 to 5% of the people. So we have to accept some reality, counseling the patient so that you are together, because many of the times they are just going to another doctor. I think you do the magic. But of course, we always say that the biggest enemy of Kenyan doctor is the other doctor, because you start saying, you are doing this and that. Some people do that, but not you people, not physicians.
Thank you. Thank you. Very nice. Yeah, Rosie, that's an excellent presentation. Maybe I missed it. Use with insulin?
Thank you. First of all, Dr. Manudhu, thank you very much for wearing purple. Happy International Women's Day. I see you celebrate us. And thank you for your question. So times 3 was a study that was conducted in combination with insulin. The initial 16 weeks was just to see imeglimin with insulin versus placebo with insulin to see the effect. One, is there hypoglycemia? Is there an added effect? They found a reduction in your HbA1c of about 0.54%. Then when they extended these patients and then they purely maintained them on imeglimin and insulin, primary was safety, because you know with hypoglycemia there's increased cardiovascular morbidity and mortality, and they found that there was no episode of hypoglycemia, and you maintained and you found a HbA1c of 0.64%. So it is still considered safe in the combination of imeglimin and insulin. And the concept here, which I'm hoping that we can be able to extrapolate and maybe see in our African population, is reduction in the amount of insulin use if you combine it with imeglimin. It is more of the concept of, would you require less doses if you use it with imeglimin? Thank you for your question.
Yeah, thank you. I'll start with Rossi because it's an easier one, me not being a diabetic. Sorry, I missed part of your talk, but I saw the slide where you compare the various drugs and this new drug, which I don't know how to pronounce.
Imeglimin.
Whatever it is. It's the only one that ticked all the boxes. And it reminded me of the excitement we had when the DPP-4 inhibitors came in. I remember my friend, Dr. Charia, used to call them the incredible incretins. And of course, we know that DPP-4s, I mean, they increase your glycemic control, nothing beyond that. So my caution, be careful with surrogate endpoints. Okay? Patients don't know what is happening in their mitochondria. They just don't know, they only care whether their heart or kidney or whatever you are damaged. So that's it. You can make a comment or not. Just a few comments on Martin's talk, which was quite extensive. I don't know how you managed to do it. It's a whole chapter, textbook on heart failure. Just a few comments. The first comment is on the definition. I saw from your slide that you used the definition of the ACC guidelines of 2013, which was a definition we used for a long time. The problem with that definition, it was a conceptual definition, but it didn't help the clinician. It's sort of defining diabetes as a state where there is insulin resistance or insulin insufficiency. The clinician does not measure insulin. So when we talk about increased filling pressures, you know, inadequate to meet metabolic demands, how do you do that? And that's why there's this new universal definition, which is much simpler. Look for this, look for this, look for that, so it is easier for the clinician. So that was my first comment. Second comment is I'm sure you didn't mean to say it that way, but you suggested that finerenone is an alternative to the steroidal MRAs for treating heart failure. At this point, we don't have the evidence. The evidence we have with finerenone is that in diabetics with CKD, it prevents cardiovascular events, including heart failure. There are trials going on. We hope it succeeds. But as of now, it is not treatment for heart failure. The next comment is that you suggested that you had this patient where you put a device and the ejection fraction improved, and therefore you stopped all therapy. Actually, in your response to another question, I think you sort of answered that. I would be very cautious of that. And maybe just one additional thing, and this is really addressed to the audience, not you, is that I saw that your patient was initially on Candesatan, Atacand, and then you changed to an ANI, which is really the practice here. We almost invariably use ARBs instead of ACE inhibitors. ARBs are not class 1A agents in heart failure. It is ANI or ACE inhibitors. Thank you.
So I think with those professorial remarks, we can promptly bring this session to a close. It's now 1:30 because I really want us to keep time so that we have our afternoon sessions on time. I'll hand over to Dr. Rosalind just to give us a few announcements. So we'll have a photo. So we'll receive our lunch vouchers. For the ushers, our Muslim brothers went to the mosque, so please keep for me 30 vouchers. Dr. Ibrahim will come and collect. For those Catholics, it's Lent season, so for those going for Way of the Cross, you can join me at 5 p.m. There'll be a bus available to take you to the Catholic Church for Way of the Cross. Thank you. Dr. Rosalind, thank you.
Thank you, Eric. Stop looking at Eric so surprised. He does go to church. Anyway, thank you so much, and we thank you for your patience. I know we've extended a bit, but a slight change to the program. Number one, because we are closing at 1:30, we expect you back at 2:30, and we've opted to push the nephrology stroke rheumatology session to 2:30. We're going to have the nephrology session 2:30 to 3:30 in Rupa Hall, which is the hall you're in right now. And for the rheumatology, we'll be at Sosian A and B, which is directly opposite the Farmhouse Restaurant, 2:30 to 3:30. Then thereafter, we quickly switch to neurology here at Rupa Hall, 3:30 to 4:30. And the research abstracts will be presented at Sosian A and B from 3:30 to 4:30. I urge the chairs, panelists, moderators to try and keep time so that we can actually give you some time to rest. Then we have team building between 5 p.m. and 6 p.m. led by our very able president of KAP. And then thereafter, 6:30, by the time you come and shower and change, there'll be buses available. Now there'll be a bus here which will take people from Eka Hotel all the way to Lions Primary. It's just 5 minutes. So they'll come the 6:30 and at 7, last one at 7:30. Similar applies. So we'll have another bus from Lions Primary at around 6 o'clock to take to Boma and Noble and Sirikwa so that you can go shower, change, and then we'll come and also pick you up from your hotels. The gala dinner theme is green and gold. Kindly adhere to that. And it's smart and elegant. We're in the home of champions. And come on, we had sent this flyer weeks ago. So we are in a mall. You have chance to go after lunch to just go and shop. But we expect you to be dressed in the nines because we have an exciting program planned. But remember, most importantly, we really want to thank the farmer for their support. So after lunch, kindly take the time to visit our sponsors in their booths. And then let's come in at 2:30. Can't wait to see who's the best dressed. Welcome. Thank you for lunch. And you're going to pick the vouchers right as you exit, or if you are not able to get it, you'll find our ushers at the Farmhouse Restaurant. Remember, we encourage you to get your steps in, so go down with the escalator or the stairs and then climb back up. We allow the senior doctors to get to the lift. You turn to your right and then just press on up, go to the 3rd floor, and you're at Farmhouse Restaurant. Have a good afternoon.